AV system works here. First of all, good afternoon. It is very good to see everyone's face for a change as opposed to virtual meetings as we have been. And I'm excited about being here to kick off this summer TNS meeting. I'm Eddie Patton, and I am the president-elect of TNS. And I'm here to introduce our Lunch and Learn program. So first of all, I want to remind everyone to use the meeting app to access the presentations. We've been going away from a lot of the paper material, printed material. So the app instructions, where they were up, if you need those app instructions, if they weren't in your welcome packet, then let me know, and I'll make sure and get those informations to you. Secondly, everyone pull out your phone, hold it up in the air. Everyone has a phone. So I would invite everyone to please get in touch with TNS. Sign up for Twitter. Sign up for our Facebook page. We are doing a lot more as far as communications, interactions through our social media campaign. So while you're sitting here throughout this conference, go ahead, sign up for the TNS on Facebook as well as Twitter. I will tell you that at the end of the weekend, we have a nice giveaway, $50 Visa card. So whoever does the most creative tweets, there's a hashtag, pound TNS2021. So I would encourage you all to use that hashtag. And there is a giveaway at the end of the meeting. So please, everyone, sign up for both Twitter and Facebook. Another reminder: the exhibit hall is open. So in between programs, please take advantage of that, the wealth of information that is there. So at this time, without any further ado, I'd like to introduce our speaker, Dr. Jeffrey McLean. Dr. McLean is a lieutenant colonel in the United States Army Medical Corps, Deputy Chief, Department of Medicine at the Brooke Army Medical Center in San Antonio, Texas. He serves as a key leader for the largest clinical and academic department in the largest and busiest Department of Defense hospital. The Department of Medicine is comprised of over 800 employees, Air Force, Army, and civilian, to include both the physicians, the nurses, the technicians, and supporting staff. Primary responsibilities include the oversight of the academic program, as well as administrative functions and human resources. I know Jeff well from a lot of the leadership programs throughout the American Academy of Neurology. He is the chair of the AAN Equity, Diversity, Inclusion, and Healthcare Disparities Joint Coordinating Council, and the vice president of the AAN Leadership Development Committee, which I currently serve on that committee. He is the chair of the AAN Career Leadership Subcommittee and the editor, board member of Brain and Life magazine. Today, Dr. McLean will be talking to us about unconscious bias in healthcare, and I welcome him, and let's give him a round of applause.
All right, good afternoon, everyone. Eddie, thank you for the invitation and the nice introduction. As he said, it's really nice to be in person with some people. This is actually my first presentation outside my institution, face-to-face, since COVID started. In fact, you may have noticed I took the stairs a little gingerly. Because I'm in the military, I wear a uniform. I haven't worn this suit in well over a year, and it shrunk somehow in these during COVID. I'm not sure exactly what happened there, but I found it was a little tight when I put it on today. So it's really good to do this despite that little surprise. So today we're going to talk about unconscious bias in healthcare. Before I do that, just a quick disclaimer. I don't have any financial disclosures or conflicts. I do want to say that I'm speaking on behalf of myself. These are my own opinions. I don't speak on behalf of the Army, the Air Force, Department of Defense, or the American Academy of Neurology. These views are my own. So I like to give this talk in an interactive way, so hopefully you all are willing to participate, otherwise it gets a little bit awkward. So what's the best way to give a presentation? You've all given presentations before. If you're giving advice to someone, when you tell them, you know, how to start off a presentation, what's some of the advice you may give them? Start with a joke. Thank you. Have you seen this before? All right, so you saved us about 5 minutes of going through all the answers I didn't want. That's the one I wanted. All right, so start with a joke. And that's pretty common advice. So if you look at advice from well-known TED Talk speakers, their secret number 6 is to have a sense of humor. And because it lowers defenses, it makes your audiences more receptive. These are commonly seen in multiple sources. So this is 11 public speaking tips from the best TED Talk speakers. And number 1 is to use self-deprecating humor. So, and I like this one in particular because this is talking about a particular TED Talk speaker, Dr. Robinson, who doesn't have a very dynamic physical appearance, and he's an academic, so he has to overcome the perception that he's going to give a boring lecture. I thought that was helpful advice for me as well. So he starts by poking a little fun at himself, and that helps make people feel more comfortable and more likely to listen to what he has to say. So you notice I made a little self-deprecating joke at the beginning, right? I poked some fun at myself. So does it work? Are you all feeling more comfortable and more receptive to what I have to say? Do you think that this is generally good advice to give people, that humor is a good way to start a presentation? Does it matter what my gender is? So I see some no's. I saw maybe a yes over here. So this is a study from the Harvard Business Review where they asked this question: does it matter the use of humor in the professional setting? Does it matter what the person's gender is? And what they did was they started with this premise that humor in a professional setting could be looked at really in 2 ways: is either functional or disruptive, and that we all have different implicit or unconscious expectations of men and women, and that therefore we interpret behaviors in ways that adhere to those unconscious expectations. And so with that in mind, will we perceive humor differently if the person delivering it is a man or a woman? So this is the study they designed to try to answer that question. They hired some actors, a woman and a man, to play a retail store manager who's going to give a recorded presentation to a regional manager who were also actors. They each recorded, the man and the woman each recorded 2 versions of their presentation that were identical, both their versions and identical to each other. And one version had 5 humorous statements included in the presentation. The other version didn't have any humor. So same jokes, same 5 jokes. They tried to get the actors, both relatively equal skill in terms of being able to deliver those jokes. Everything else the same. They showed these to 300 employees from various industries across the U.S., and they gave them also a work history and a resume that were identical other than the name. So everything the same was presented: humorous, non-humorous, male, female. And here's what they found: that with the humorous presentation, the woman's use of humor was consistently scored as less functional and more disruptive, whereas the man had higher perceived status, performance, and leadership capability. And here are some of the comments that people made about it. So when talking about her, they said she showed poor judgment in jokes, and that her use of humor was really trying to cover up her lack of business acumen. Whereas his use of jokes was witty, and he was trying to make sure that he didn't come across as too stern. And that he added a touch of humor to break up the monotony of his presentation. So very different perceptions based on just the gender of the speaker when everything else was the same. So why is this? What causes this? And how many of you have seen this book or heard of it, Thinking Fast and Slow, by Daniel Kahneman? He's a Nobel Prize winner in economics. And what he talks about are two systems of thinking, and this is, whether you've seen the book or not, this idea is not going to be foreign to anybody here. System one thinking being our sort of fast, automatic, continuous thinking that we do effortlessly, quickly, and automatically. And it's very easy. It doesn't take up much energy. It obviously doesn't require our conscious attention. The problem with it is that it's prone to errors, right? Our system two thinking is our more deliberate, more effortful, more intentional thinking that we tend to only use when it's necessary. And that's much slower, but also more reliable. So in medicine, when we're providing care, what all would you say we use most frequently, system one or system two thinking? System one? Right, it's funny, I have given this talk a few times, and depending on the specialty I'm talking to, it's very different perceptions, and I don't know if we have any neurosurgical colleagues in here before I say. You can make the joke for yourself. I'll skip that joke. But what I'll say is that I think probably many of us underestimate how much system one thinking we do when providing care. And if you think about even the way we're educated, it's to take a lot of information and quickly put it together and recognize patterns and get quickly to an assessment and make our choices, make our diagnosis, make our treatment plan. And we don't often spend much time just stopping to deliberately think, right? The whole process, you're either taking your history, doing your exam, but you're thinking at the same time, and you don't stop and, in most cases, stop and deliberately pause and think. So I think there's a lot more system one thinking. Also, system one thinking is quicker, more effortless. So how many of you have a lot of spare time in your clinical practice? I think probably most of us do not. So our system is sort of set up also to kind of nudge us towards system one thinking. Stepping back a little, just thinking about other day-to-day examples of system one thinking and how it can impact us. This is an example that I have fallen prey to multiple times, and hopefully others as well, so I can feel a little bit better about it. I split driving my son to school every day with my wife, and so I have one route that I drive some days and one route that I drive other days. And many days, too many, I get in the car with my son and take the wrong route because I'm driving to work instead of taking him to school, or vice versa. Anyone else have that problem, or is it just me? Okay, good, thank you. I feel a little better. That is a point that I really like to make, because what this is when we're talking about the system one thinking, or getting to what we're going to get to when talking about unconscious bias, the point here is that when we use this fast thinking, we're prone to making errors that at times may conflict with our explicit intentions. When I get in the car, I'm intending to take my son to school, but I do something that's is directly in opposition to that because I'm using that fast unconscious thinking rather than that system two thinking. And that's why this is not about people not wanting to provide the best care to all patients. I think all of us get into this profession because we want to provide the best care to all of our patients. But sometimes because of the system one thinking and the errors it makes us vulnerable to, we may make choices that are contradictory to those good intentions. And I think we're all, especially in medicine, taught to trust our instincts and to believe in our instincts and to believe in our training. And in many cases, that's a good thing. But sometimes our instincts and our system one thinking may fail us and lead us astray because they can be misleading or unfair unconscious beliefs that we have. So here are some other examples outside of medicine in different industries of fast thinking. I'm going to go through these a little quickly, but feel free to jump in if you have thoughts or comments or questions. This one you've probably heard. It's been done in many different settings, different ways, but what they do is they take resumes that are identical. They give them to managers asking if they would interview this person. Everything's identical except for the name at the top. They do half with a name that would be typically associated with an African American, and half that would be typically associated with a white person. And the ones with black-sounding names are about half as likely to receive a selection for interview, and with everything else being the same. Another study in academia, when having faculty hiring a lab manager, they looked and they controlled for qualifications, background, experience, and they found that the men were consistently rated as more competent and employable. The men were offered higher starting salaries, and they were offered more mentorship when compared to similar women with similar qualifications, experience, and background. Multiple studies have looked at CVs in academia where similar to the resume one we talked about, everything else is the same, everything else is equal, but if there's a man's name at the top versus a woman's name at the top, the male CV will be rated as higher and someone with higher qualifications. This reminds me of a colleague of mine also from the AN leadership programs. Some of you may know of her, A.M. Barrett. I don't know if you've heard of her. She's a full professor, highly accomplished, has done a lot of work in behavioral neurology and neuro rehab. Amazing speaker. She's done some TEDx talks. She's very just an amazing, very accomplished neurologist and researcher. She goes by AM, and when I met her, I asked her why, and it's because of this. Early in her career, she felt that she wasn't getting the same opportunities and the same reviews in terms of her papers that she submitted for publication. When she was submitting for grants, she felt she wasn't being looked at the same way as some of her male colleagues. And so she started deliberately in all her professional dealings going by AM. And so all of her papers, all of her work, it's just her initial, so you cannot tell whether she's a man or a woman. And she has noticed a significant change in the response and a significant increase in her success in getting grant funding, getting opportunities. Of course, that's an N of one, that's an anecdotal report, but I think she's probably not alone in that. And I think if we look at the objective data that we do have looking at trends, there's certainly evidence to support, in our field in particular, that women often have fewer opportunities, and certainly our field has been one of the worst in terms of gender pay equity in the field of neurology compared to other specialties. This last one I think is interesting. What they did here was they generated a fictitious legal memo and had it reviewed by legal partners. In the memo, they deliberately inserted 22 errors, and those errors could be based on grammar, spelling, analysis, or facts. And they distributed these again to partners and law firms to review the quality of the memo. The only difference was for some, again, the name of the author of the memo was a name that would typically be associated with a white person, and on some, the name was one that would typically be associated with a black person, and consistently, the evaluators found more of those 22 errors when the name of the author was a black person. So all of these things, I believe, demonstrate this fast thinking and how it can lead to decisions that may be against our conscious beliefs. In most of these cases, I don't believe that these people are intentionally discriminating against women or against underrepresented groups. But we all, over time, over our lifespan, sort of absorb beliefs, associations, and assumptions that may unconsciously impact some of the decisions that we make. And that's really what we're talking about when we talk about unconscious or implicit bias. These associations, these attitudes, these preferences, these assumptions that we just sort of learn and absorb over the course of our lifetime from what we see in the media, what we read, what we just grow up around, and we're often unaware of that we even have these beliefs or assumptions, that we're making these assumptions, or where they come from. Despite the fact that we may not be aware of them or where they come from, they can have a strong impact on our choices and on our actions because we're so often using that system one thinking when we're making choices and actions. In fact, an individual's behavior can often be more reliably predicted by their implicit or unconscious beliefs than what they consciously state as their values or intentions. And that's again the example of I intend to take my son to school, but unconsciously I'm thinking something else and I go in a different direction. I want to make a couple other points about this. One, this is not the same as racism. This is not generally, in this context, at least when we're talking about racism, we're talking about a conscious, intentional, and explicit discrimination against race, or sexism, the same thing towards gender. This is something that is unconscious, unintentional, but may still have some negative impact. And the other point is that we're all vulnerable to this. This is not a problem just of white men. This is something that we are all susceptible to because we've all grown up around these images and all these things that we absorb from our environment. In the first study that I talked about with humor and women, women also rated the woman as more disruptive with her use of humor. It wasn't just men that rated the woman as more disruptive. Often underrepresented groups hold negative views towards those in their own groups as well. These are things that unfortunately none of us are immune to. So it's not a issue of pointing fingers at certain groups. It's something that we all are susceptible to and all have to just be aware of and try to take steps to mitigate. So I've given a number of examples. What about what's the evidence for the presence of this in medicine? So this was done back in 2017, a systematic review of papers that were looking for evidence of unconscious bias in medicine. And they looked at 42 articles systematically. And of the 42 articles that were looking for evidence of implicit bias in healthcare professionals, 35 did demonstrate evidence of implicit bias, mostly in terms of race, ethnicity, gender, age, or weight, although there were some others as well. Not all of the studies looked for a link between the presence of implicit bias and healthcare decisions or the quality of care delivered, but those that did, there was a correlation between increased presence of implicit bias and decreased quality of care. Here's an example of one of these studies. This is an older study, but I think a useful one from 2007, looking at implicit bias in the decision to administer thrombolytics in the setting of acute coronary syndrome. They looked at 287 internal medicine and emergency medicine residents at 4 different academic centers. Of the 287, none expressed an explicit preference for a certain race, white versus black. They only looked at the 2 races because of the patient populations at these academic centers. So there was no explicit, conscious expression of preference. However, they used implicit association tests, which we'll talk a little bit more about later, to look for the presence of implicit or unconscious preference. And there was a significant preference for white Americans, as well as an implicit belief that blacks are less cooperative with medical procedures and less cooperative in general. And what they found in doing clinical vignettes then with these residents where the appropriate choice was to administer thrombolytics, these residents that had these pro-white implicit biases were less likely to administer thrombolytic, to choose that in the vignette, to Black patients. So what about in our field? What about in neurology? This is actually a slide that I like. It was actually, I have to give credit, put together by one of our leadership programs, the Diversity Leadership Program back in 2017. And they put together this listing of different areas within neurology where studies had been done looking for disparities in care. This wasn't specifically implicit bias, but disparities in care. And what I like to point out here is a couple things. One is that this is fairly widespread throughout our field, and I could do a similar slide for just about any field in medicine. The more we look for these things, the more we see that there are differences in terms of health outcomes that are based on people's race, gender, weight, and various other factors. And it's found pretty consistently. The other thing that I like to point out here is that often people think that these issues, when we talk about implicit bias or when we're talking about healthcare disparities, that they'll just sort of automatically get better over time. We're becoming a more diverse society. We're becoming a more diverse medical field. So these things will sort of work themselves out on their own. Well, I would suggest that the recency of some of these studies and increasing studies that are currently coming out would argue against that. These things don't just improve on their own. While we've certainly made strides in terms of explicit racism and conscious discrimination, these unconscious biases that all of us unfortunately carry around and have absorbed are still unfortunately alive and well. And if we don't do something consciously and intentionally to combat them, I don't think they're going to just resolve on their own. The last point that I'll make is the one about multiple sclerosis research here. What they were looking at was really the patient populations in some of the MS therapeutic trials. And what they found was that underrepresented groups, primarily people of color, were underrepresented even compared to their demographic distribution in the United States. So patients of color were underrepresented in the research studies that help determine what is the best care. I think that's important because even if you're using the best available science, and even if you bring no bias to it, our system and our research and our best available evidence may in fact be biased against certain people because those people were not included in the research and the science that determine what is the highest standard of care. So it's something that, again, this is pervasive and something that if we're not intentional and if we're not thoughtful about this, it's not going to just fix itself. So what can we do about this? There's a lot of evidence that this problem exists. There's a lot of evidence that implicit bias is very common. There's a lot of evidence that it also is present in healthcare professionals. There's some evidence, and I think increasing evidence, that the presence of that implicit bias correlates with poorer outcomes and lower quality of care for some people. There's much less evidence to tell what you can do about it that actually is effective as a strategy to mitigate these biases. There are some suggestions, there are some thoughts that are reasonable, and there's some people doing work to try to demonstrate evidence to support a particular intervention. But here are some suggestions to at least think about it while we're waiting for more clear data. I think one is very important as a starting point is to look for our own blind spots. How many people have taken an implicit association test? I see A few hands. So how many have heard of implicit association test? Okay, so some. So the idea with an implicit association test, and I should probably put a slide in that demonstrates this a little bit better, but the idea here is that it's a test that you can take on a computer. It takes about 10 minutes. There's a project and it's hosted out of Harvard. They have it on their website. You can go. There's no cost or anything like that. I have the link at the end of my talk here. And what they do is they show you images of different people and certain words that have positive or negative connotations with them. And by testing how quickly you can associate certain words with certain people, they use that as a way to try to assess whether you have a more difficult time associating positive words, positive characteristics with certain groups of people, whether it be women, whether it be people of color, whether it be certain religions. They have different tests for different categories of potential bias. And so what it does is it assesses your timing and accuracy in being able to associate those groups with positive or negative characteristics. I would highly suggest that everyone take the 10 minutes to do at least one of these, then maybe do some more, and just try to see if you may have some blind spots in terms of what you're bringing to your patient care. Again, all of us, I believe firmly, get into this field with the intention of taking the best care of everyone. But is it possible that when you're seeing patients in clinic, that you may make some assumptions about some of your patients that lead to you making decisions about those patients that may not be fair? So for instance, is it possible that you may assume that a black patient may be less cooperative? We've seen that's present in healthcare providers. And so therefore you give them a less complicated but perhaps slightly less effective regimen for management of their neurologic disorder. I think that's a feasible scenario and one that's been borne out in at least some other studies in some other fields. There are certainly studies in the pain management arena where people have implicit unconscious beliefs that black people are less sensitive to pain, and so therefore they, with the same injuries, are treated with less pain medication because it's not an intentional discrimination, but an unconscious belief that black people just are more resistant to pain or less susceptible to pain. These are the kinds of pervasive unconscious beliefs that people have that can impact some of our thoughts and ultimately some of our actions. In addition, I'll give you another example. In my institution, we often, in the military, there's an assumption that because, in the military hospital, there's not really an issue with healthcare insurance. Everyone that comes to our hospital, except for traumas and things like that, everyone that comes to our hospital is a beneficiary and has full access. So that part is taken out. So there's sort of an assumption that gets rid of healthcare disparities. Well, as we look, we find that that's not really true, because that's not the only driver of healthcare disparities, is not socioeconomic status or insurance or level of education, which we also control somewhat for. I believe is a large part of it that is unconscious bias, and that part we have not removed. So in our facility, we looked at our TPA administration for men versus women, the patients. And what we did was we looked at both door to needle time, and we also looked at alert to needle time to get a sense of, for our neurology team specifically versus the entire process. And in both cases, at our institution, women have prolonged time to receive TPA for acute stroke. Why is that? Our study doesn't tell us exactly why that is, but I suspect that it's because as a whole, the women's symptoms are not being given the same weight in evaluating the patients, and therefore having the same urgency in getting to the outcome. Now, we're just talking about patients that ultimately did get TPA, so these are people that the decision was made that this person should get thrombolytics, but for women, it's just taking us longer. And that's something that I think we really need to look at and think about why that is. And we're looking at now, can we do an intervention to change that? And so far, we have not been successful, but we're still going with that study, so we'll see. Maybe in a future talk, I'll be able to talk about a successful intervention for that. So some other things, once you're aware of potential blind spots, once if you can take an implicit association test and get a sense of what blind spots, what biases, what system one thinking errors you may be bringing to the table, what else can you do? So consciously trying to combat stereotyping. So what do I mean by that? So we are all good test takers, right? We got to this point by being able to be, most of us at least, are pretty good test takers, and so you know sort of how to take a little bit of information and make a decision, and sort of what's the most likely answer, and we all associate certain keywords with certain choices, certain diagnoses, or certain treatment options, because we've taken lots of multiple choice tests. And so we sort of are trained to think of things in probabilities and groups. And again, there's nothing wrong with that inherently, but that sometimes, even if something's 90% likely for a particular group, it may not be right for that individual patient. So trying to really think about patients individually and not think about groups, but think about individuals and try to confirm what's correct for that individual. Another thing, and this may sound trite or cliche, is trying to put yourself in the patient's shoes. The reason for this is if you put yourself in that patient's position and think about what you would want, or if you would want if this was a family member, it may help you alleviate some unconscious bias or unintentional bias that you may be putting onto or baking into the decisions you're making when you change that perspective up. So that's another thing that can be tried. So I'm gonna stop there. I have just about 10 minutes left, which was about how much time I wanted to leave for questions, answers, question and answer, and discussion. This is the link for the implicit association test that I mentioned. Again, I highly encourage people to try this. I will say I took this. I was surprised at some of the results I found for myself. It's private information. It doesn't get out. It's really, I find, a helpful tool so that you can at least potentially identify what are some areas that you may have where you can, if you're bringing some potential bias to your patient care, you can maybe stop and take a couple extra seconds in your appointment with patients that are women, or with Black patients, or with Muslim patients, or disabled patients, or overweight patients. All of these groups have been shown to have disparities in the outcomes of their care. And at least some of that, I believe strongly, and I think there's increasing evidence to show, is coming from unconscious bias that we're bringing to our clinical encounters. So if we can find what biases we may have and take a few extra seconds to force yourself into that system two thinking, to be deliberate, to be conscious when you know, okay, this is someone that maybe I'm making assumptions about this person and that's coloring my decisions. I think we can make some progress in this area. So again, I will stop there. Any questions, comments, feedback, please?
Just interested that, were you able, have any of these studies been able to see if there is implicit bias in other words, do black physicians have the same bias against black patients? In other words, do black physicians treat, and the same with obese physicians, females, it'd just be interesting to know.
Sure.
You know what I'm saying? Does that
Yes.
bias carry across
Yeah.
all of the different groups, in other words?
Great question. Could everyone hear it, or do I need to repeat? You guys could hear over there?
I wanted to add an age. Are younger people getting better at this than older?
Okay, so two parts of the question. So one, do black physicians or obese physicians or women physicians have the same potential biases against patients in their own groups? I have not seen that study specifically for physicians, but for instance, in the study of women and humor, the women also rated the women's use of humor as less disruptive. Consistently, when looking at the presence of unconscious biases, the answer is yes. I haven't seen it specifically for healthcare providers, but for instance, you know, their unconscious biases towards women in terms of career achievement and capability. Again, women also have those biases. There have definitely been studies looking at particularly black children absorb some negative associations with people with darker skin. You know, even though they themselves have darker skin, they associate that with negative connotations. So there's ample evidence that that does exist, that unfortunately, again, we all absorb these, and being black or a woman, obese, whatever the case may be, doesn't make us immune to those things. I haven't seen it specifically in healthcare. To the question about, is this better when you look at the younger generation, is this getting better over time? Again, I don't know I haven't seen anything looking specifically at older physicians versus younger physicians, but in other studies that have looked at, again, just implicit or unconscious bias overall, and looking at older versus younger, those things are still there. Because while, again, we've made significant progress in terms of explicit, conscious, deliberate racism, I'd argue we still have more to go, but we've made progress certainly there. This unconscious implicit bias is so pervasive and often so underappreciated that we still have a lot more to do, and growing up in more diverse settings doesn't necessarily help automatically, because we're still so surrounded by images, associations. I mean, you think about what we all see and absorb, whether it's from television, internet, all these different things. Those have such a powerful and profound impact on everyone, still, young, old, it doesn't matter. And so we're all still absorbing these. Eddie.
I have a question. It seemed like after George Floyd and a lot of these things that were going on in our country, you saw this awakening of a lot of organizations forming these diversity and inclusion committees and so forth. Is there any evidence so forth or now that they have worked and been effective organizationally to decrease some of these implicit biases?
Yeah. Again, a good question, but I haven't seen any evidence of anything that's been proven to be effective for this particular problem, or some of the broader issues with equity, diversity, inclusion. I haven't seen anything that's been proven to be an effective and lasting intervention. There have been some studies that looked at in different industries, things like mandatory diversity training or cultural sensitivity training. And often those have a impact on when you look at studying people's explicitly stated beliefs, but when you actually look at people's behavior and choices outside of a explicit question related to it, they were not effective in changing their choices, especially the farther you go out from the training. And in fact, somewhat paradoxically, or maybe not surprisingly though, when you make those kinds of things mandatory, often you actually have the opposite effect because it frustrates and angers people and sort of hardens some of their beliefs, unfortunately. So it's a very challenging topic, and I think the belief is, although there's not great evidence, is that trying to appeal to people in a way that makes it clear that it's not an attack on them or that they're not being singled out or not being accused of being racist for these issues, for this unconscious bias, will allow people to see how their unconscious beliefs may be getting in the way of their explicit or conscious intentions. And so hopefully that's what I've tried to make clear here. That's, I think, what is ultimately going to be the most effective intervention, but hopefully more to come on what actually works. Any other
questions?
questions?
Please wait one second. Remember, this is virtual and live, so.
Ambas. So my comment is that I wonder if one of the way to assist with avoiding this is really sometimes it's a historical relationship with that particular patient, because I definitely know I have implicit bias with young patients, for example, being very cavalier about taking their medications correctly, being very compliant. But over time, having had a history with some of these patients, it appeared that they are not that way at all, that they are actually quite conscientious and quite compliant. And then over time, my own implicit bias have changed. And so I think that it's going to have to be an individual, like you mentioned already, an individual basis, not only as the professional, but with each individual patient as well.
Absolutely, thank you for that comment. And I think, as you said there, I think it really gets back to the point about individuating the patient and learning about that individual. And the more time we have with the patient, the more opportunity and the easier it is to do that. I think the difficult thing about that is that in many of these cases, we don't have that time before we're making some of the decisions. So if you're thinking about a stroke evaluation, there isn't that time to develop that relationship. And so again, what biases are we bringing to those? But absolutely, that demonstrates the importance of really understanding that individual and not attributing things to them that may or may not actually be true. Thank you.
Getting my steps in.
My question is about one of the examples of a bias you mentioned, which surprised me. Most didn't, but the one about delayed time for TPA for women versus men, for the ones who did get TPA.
Yes.
That was one that I just had a hard time wrapping my head around as to why that would be. And so when that kind of thing is observed, do we just have to look if there's an operational problem at an emergency room setting where women are being treated differently in terms of what processes are done, that they're having to do testing to make sure, pregnancy test, whatever it is, that is delaying things, so that they should do things in a more expedited manner? Because it seems like bias shouldn't be involved in that at all. And so maybe there are unknown factors that would cause delays, and it's not really so much bias, it is just not doing things in a good stepwise manner.
One thing I thought of, they've always talked about the atypia of MI symptoms in women, so I wonder if that's it. They just don't have the typical symptoms as often. you know, that's just another possible explanation.
So I guess the question is there a chance for education on this so that the bias would just completely disappear as long as we understand the problem better?
Yeah, I think it's a great question, and ultimately, I don't know the answer. We're trying to figure it out and get a better grasp of what exactly is driving that difference. Again, what I would suggest is, I think there is ample evidence out there that healthcare providers often are more likely to believe that a woman presenting with symptoms, it's psychogenic in nature than a man with the same symptoms. I think that's unfortunately a fairly common phenomenon. And so if you have someone presenting with primarily subjective sensory symptoms, that's a woman versus a man, might it be more likely that people are, again, moving with less urgency through the process, both in terms of calling the stroke alert and also then what's relayed to the neurology team, hey, we're calling this, but we don't think this is real. And then that just slows it down, but why is it slowing down? Is it all based on the initial perception? And we all make initial perceptions, right? We walk into a room, is this somebody who's really sick? Is this a real stroke or not? We make those snap judgments. How much of it is based on just the person's gender? I believe, based on this, that there's a good chance that more of it is based on the gender than should be.
I think sometimes it even makes a difference on how seriously a woman is taken by who's with her. If her husband's there with her or her children, as opposed to if she's there by herself.
I think that's a great point. I've seen that, and I've certainly heard women explain that, whether it's in medical settings or others, that they unfortunately feel like they need to have their spouse or someone else there to validate what it is that they're saying. I think that's unfortunately a fairly common phenomenon that really gets to the same thing. I think Eddie's going to have to walk me off the stage here.
This is a great topic, great discussion, and I'm going to volunteer you because I know you told me earlier you'd be hanging around.
Yeah.
So Jeff will be around the meeting. So in between or so forth, please feel free to answer any additional questions. But let's give Dr. McLean another round.
Thank you all. I appreciate it. Thank you. Thank you, Eddie.
We're going to go, well, though, we're going to go ahead and get started. Welcome, Dr. Volpe. Welcome to the Texas Neurological Society Summer Meeting. This is the first in-person meeting we've had since February of 2020, and that's what real people look like. I haven't seen that in a long time. Usually you're on like little separate screens on my computer, but does anybody know what kind of jokes you tell in a quarantine? It's inside jokes, right? Inside jokes. And do you know why they call it the novel coronavirus? It's a long story, right? But seriously, in Houston, I know that I just received email from Methodist. We have double the amount of COVID cases in the ICU, right? It's 185 today. There was 100 over the weekend. So we take this very seriously. I do request that people wear masks when possible. I hope everybody is vaccinated, but we think that offers protection, but yet we want to protect our unvaccinated colleagues and others that may be in our environment. So please be mindful. We would request that people try to wear masks as much as possible. And let's not be in the newspaper as a super spreader event for Delta Plus or whatever the new Greek letter is going to be. I would encourage everybody to use the meeting app for presentations. There's both a virtual, we have about, I forget, 50 people, I think, that are virtual, or maybe 25 virtual people out there. And so they will use the app for questions in the chat component, and we can do the same with the app here. So use your laptops or your phones and download the meeting app, and I hope you've all done that. Okay, my name is Gary Clark. I was supposed to do that first. I'm the current president of the Texas Neurological Society. Again, welcome. We also want to encourage the use of social media, so I'm going to have Eddie talk about that a little bit. Eddie Patton.
And I mentioned this before Dr. McLean's talk, but everyone reach out, grab your phone, hold it up in the air. Everyone has their phone. So now, as I'm getting the phone call. And all those who are virtual as well, you can do the same thing. We're really pushing as a society to increase our social media presence. As you can tell from this meeting, we are trying to reduce the amount of actual paper content and information. We share a lot of great information through our social media outlets, including Twitter and Facebook. So we all are sitting here with our phones. Take a second, sign up for the TNS Texas Neurological Society Twitter account, as well as the Facebook account. Some incentives, because we all like incentives. At the end of this presentation, there will be a $50, I think, Visa gift card. So be creative with your tweets. There's a hashtag. I left the hashtag. What was the hashtag?
It is TNS.
Kai, what's the hashtag? Oh, you got it?
I got it. TNS 2021.
Yeah, so hashtag TNS 2021. So we will be giving out awards for the most creative tweets at the end of the program. And please follow us on our Twitter and Facebook. Thank you.
Yep, and no trolling. Okay, I would like to introduce Dr. Olga Wan, a very special introduction, who will serve. She has been the program director for the summer meeting, and she will serve as the moderator for this session.
Okay, thank you, Dr. Clark. Good afternoon and welcome back. It's been a while since we saw each other, since you saw each other, so it's good to be back, I hope. Before we start, few housekeeping items. So as Dr. Clark mentioned, meeting app, this is where you can find presentation slides. This is where you can and should submit evaluations for the speakers. And this is where we would ask you to submit your questions. So please, those who are attending in person and those who are virtual, submit your questions in Q&A section, and I will read your questions to a speaker at the end of his or her talk. This is how we prefer to handle it. Today, we will have a short break, 30-minute break at 3 p.m. It will be in exhibit hall. Please attend exhibit booth and attend as many as you can. For those who feel adventurous, fill out and complete your exhibit passport to be enrolled into a prize drawing. Please don't miss this opportunity. We will have welcome reception today at 5:30. Please join us to socialize, to meet new friends and old friends. It would be great. To claim your CME, you will receive a link in the email. Just follow this link, and this is how you can get your CME certificate. You will get this link at the conclusion of this meeting. And that's all I want to say, and let's start. It's a great pleasure for me to introduce our first speaker and my colleague from Houston Methodist, Dr. John Volpe. Now, Dr. Volpe graduated from medical school at Baylor, and this is where he completed his neurology residency training. Dr. Volpe is a specialist in cerebrovascular disorders. He is also a specialist in neurocritical care. Dr. Volpe takes care of patients with a variety of cerebrovascular conditions, CNS infection, brain trauma, and today Dr. Volpe will talk about non-atherosclerotic stroke. Welcome, Dr. Volpe.
Thank you, Dr. Wallen. Thank you, Dr. Clark, Dr. Patton. It is nice to see people in real life. I had the opportunity to bring my children to the meeting and offered them the opportunity to sit in and hear Dad talk. And they said Olympic rowing preliminary rounds were more interesting, so they would watch that instead. You know, it's so much in cerebrovascular disease that one can talk about and that one can get into. I think that our advances in acute stroke and our advances in antiplatelet therapies, I think you'll hear about that even tomorrow morning, have been getting a lot of headlines, and that's wonderful. Those have been real revolutions. But what really is the joy of the profession for me, it remains diagnosis. It remains being able to see a case and go through it and think of all the things it could be. And so many of those, you know, obviously we know about atherosclerosis, but so many of the things we need to be thinking about are the non-atherosclerotic stroke. And I also think that somewhere at a conference called maybe the Texas Cardiology Society right now, somebody's giving the same lecture, but the title is called How to Convince Your Neurology Colleague That It's Not AFib. You know, because when you see that patient who does not have atherosclerosis, I think we're looking for a lot of AFib, and that's the right thing to do, and that's what we're attuned to with things like the Stroke AF study recently. But there's more than just atherosclerosis and AFib, and so that's really what I want to hit on. As I started to put together the list of what makes up non-atherosclerotic stroke, you know, if you look into what's out there as either review articles or different texts on this, it's obviously a huge list. And I tried to put things together into some categories, and before long I ended up with a lot of categories, and there was no way I was going to be able to cover all of this. So I'm not in any way going to try to hit on everything. But I would say if you take a little bit of a 10,000-foot view of these disorders, what does sometimes stand out about them is the scattered ischemia, that often when you are looking at that MRI and you're taking your first look at it, that the patient often does have scattered ischemia with many of these conditions. And not to poke too much fun at ourselves, but it's not always emboli. So even when it's scattered, to really think about how these other conditions can mimic, you know, more than one vascular territory, more than one area, and maybe not even a vascular distribution. And the other point to make about so many of these conditions is that it has a lot to do with where you're practicing. So if you're fortunate enough that you're in an environment where you are seeing pediatrics, some of these conditions will be prevalent. If you're in an environment where I am, where it's mostly adults, you probably won't see as much of some of these genetic disorders. But they do present at different times in life, so keep in mind that our you know, where you're at will also influence a good deal of the different disorders. So how am I going to take on this large topic? And what I decided to do is to think what I've kind of learned in the last year about these conditions, what has kind of stood out to me in my own kind of learning, and really to hit on a couple quick pearls about 4 conditions that I think we see frequently. And to go through some just tidbits that I've learned about those four, but then to really take a deep dive into conditions that I think are the more important for either that they're treatable and it's important to diagnose, or that they're new things about them. And so I'll be doing a little bit of a deeper dive into sickle cell moi dissection and PFO, hopefully time permitting. I make sure we'll stick to the schedule here. If I, by chance, don't have time to get through it all, really, the slides are fully available. So with our quick tidbits, the first one I want to point out is maybe the most common non-atherosclerotic stroke is a hemorrhagic stroke. So a hemorrhagic stroke I won't be discussing in detail here, but if we look at the ischemic findings that one sees in a hemorrhagic patient, this is probably something that you're being asked to see, maybe to manage a little bit of what's going on with the bleed, but really, oh, by the way, there was a diffusion-weighted abnormality found on the MRI as well. What do you think of that? And so just to point out that about half of patients with intracerebral hemorrhages do have diffusion-weighted abnormalities. So you can fully expect to find that. It's typically in that perihematoma region. So diffusion restriction, interstitial space being compressed by the hematoma itself, that's what that diffusion restriction is. But in a significant number of patients, about 4%, there's a remote ischemic infarct. And that does correlate with an increased risk of recurrence. So what might that suggest? Well, that may suggest that the patient had an ischemic stroke with hemorrhagic conversion. So to really be thinking that when we see even a tiny distant infarct, it may be a clue that this patient has some underlying ischemic source, and that ischemic event then on the hematoma side had hemorrhagic conversion. Other possibilities, what happens with a hemorrhagic stroke often is very high blood pressure. So extreme hypertension in a patient with underlying atherosclerosis could certainly cause infarct anywhere. What else happens is that patients come in with very high blood pressure and you lower blood pressure. So you take that patient who has maybe 220 systolic and get them down to 150 within 12 hours. That patient's diffuse atherosclerosis in their brain may not tolerate that, and that may be where the infarct came from. And then the infarct or the hemorrhage itself may cause impairment of the venous system, and so the venous system creating some back pressure, some dysregulation, those could be sources of these ischemic events. TGA. So TGA, transient global amnesia, is probably that one kind of Sherlock Holmes diagnosis that we all get to make. You get to see it like maybe once or twice a month, and everyone's very wowed because it's such a dramatic presentation, and yet it's nothing to be worried about. Relatively benign condition. And important to note, because it is a benign condition, because it's something that we don't want to overburden our patient with a concern about stroke, to point out that it's very common to see kind of these dot signs in the hippocampus, these diffusion-weighted abnormalities in the hippocampus. In fact, in one series in which they did early MRIs on patients, 11 out of 12 had these tiny diffusion-weighted abnormalities. Although we associate diffusion-weighted abnormality with infarct, I think what this is the same as with the large hematoma. There's an association with TGA venous drainage, and a patient who has impaired venous drainage is probably having a little back pressure and creating a little bit of focal edema there in the pericellular space. So for those patients, I do not consider that a stroke. So for their diagnosis, they remain with TGA as their diagnosis going forward. Their prognosis is that of TGA. It's not a stroke, and I don't put them on long-term antiplatelets for that. And then what I think is a condition that has more names than any other that we have, more competing names. If you like eponyms, this is the Call-Fleming syndrome. If you like negatives, it's pseudovasculitis. If you like abbreviations, it's RCVS. So this is the reversal cerebral vasoconstriction syndrome, or if you like descriptive, thunderclap headache. So with all these different names, it's really all essentially the same underlying disorder. And it's this vasospastic cerebrovascular disease. The patients who are at risk, pregnant women, and in particular women who develop preeclampsia with pregnancy, that's going to be your patient population that you really have that dysregulation of autoregulation and can develop our CVS. Medications and toxins that the patient may take, they're listed here. I won't read the whole list. But the key characteristic is that headache, that thunderclap headache at onset, especially in a patient who has recurrent headaches, is important diagnostically, specifically to avoid overdiagnosing vasculitis, primary CNS angiitis or systemic vasculitis. The appearance, the reason it's called pseudovasculitis is because on angiogram it looks the same. This kind of appearance can look very much similar to CNS vasculitis. But having that headache is important to recognize that these patients are often treated with anti-vasospasm medications or nothing, versus a patient who has angiitis is going to be treated with steroids and maybe even chemotherapeutics, which have a whole litany of side effects that you don't want to give to a patient who doesn't have that disease. So I actually have never used this score, but I found it, and I thought I would include it here to recognize that you get points for looking at your patient's diagnostic presentation. Do they have a recurrent or thunderclap headache? If positive, they get 5 points. Was there any involvement of the carotid artery? Was there any vasoconstrictive triggers? Was there any subarachnoid blood? And was there, female versus male? And then this score is like most, if it's higher, it's more likely that it is, and if it's lower, it's less likely that it is. But just to point out, really, it doesn't take that much to get 5 points. If it's very severe headache gets you 5 points, and that is a highly accurate diagnosis for RCVS and different from other conditions that might present similarly. And the other will be our cerebrovenous sinus thrombosis. And this is a condition that can present as a kind of an ischemic, scattered infarct that looks like a watershed ischemia. And these patients who have watershed ischemia, it's because they're not perfusing distally, because the pressure from the venous system at that point is highest. It can be unilateral. So again, if a patient has a congenital difference between their venous system on the right versus the left, it may present more on one side than the other, and that's pretty common. And then I've listed common conditions. The one that we'll highlight now, it's summer in Texas. So dehydration is high on that list, and dehydration, certainly we see that in people who young people often exposing themselves to long, hot summer days and not drinking enough. Our older patients may be more vulnerable. But also keep in mind your patient who comes in after a bout of diarrhea. So like that kind of patient having a stroke, you want to be thinking of the venous system as a possible source. And then the arachnoid cyst. So a patient who has a congenital arachnoid cyst are at increased risk of cerebrovenous sinus thrombosis. We have an interesting news item with our vaccinations regarding, in particular, the Johnson & Johnson vaccine having this autoimmune reaction to platelet factor 4. That's what's causing this cerebrovenous sinus thrombosis, so you should be aware that that's the mechanism there. But it's very common not in the vaccine population, but in the heparin population, being induced by HIT or heparin-induced thrombocytopenia. In those cases, keep in mind the clotting, and we may be seeing the cerebrovenous sinus thrombosis as the only source of clot, often precedes the drop in platelets. So where is this patient? Where is the pitfall? It's the cabbage patient who you're asked to see on rounds. It's the patient who just went through a procedure and may be on some heparin, and they've had some stroke symptoms, but their platelets haven't dropped yet, but a day later they will. So if you have that suspicion, if you're concerned that you're seeing all of a sudden a hypercoagulable condition in a 65-year-old who didn't have it before, HIT would be pretty high on the list, and you can send that platelet factor 4 antibody to investigate. This is what it looks like if you do a with contrast CT, the famous empty delta sign, but the symptoms are more important than the CAT scan in this case. Usually it's a progressive headache, a headache that's often worse with exertion, a headache that's the opposite of a spinal headache. It gets worse with lying down. The patients will have papilledema, seizures, and focal deficits, and unfortunately progress to coma. So recognition is very important, very treatable, and you can do those CTAs, which we're doing all the time now for arterial. They can include the venous phase and get you those answers. You can do MR venograms. It's important that the patient be cooperative and lie still. And of course, cerebral angiogram is the most sensitive. For cerebral venous sinus thrombosis treatment, remember our equations for central perfusion pressure is MAP minus ICP. So these patients have an elevated ICP. So in this case, we do not want to lower blood pressure. You want to keep that MAP up during the early stages. So this is a bleed potentially in which you don't want to lower blood pressure. You do want to give heparin. Again, this is an atypical scenario. You're giving heparin to a bleed, as well as generous IV fluids, often keeping the patients as high as 150 cc's an hour. Even if the bleed is there, as long as the patient's stable, continue heparin. If the patient's not stable, consider hemicraniectomy or consider endovascular clot retrievals in the venous system. Worthwhile to do EEG monitoring, worthwhile to consider lumbar drains. Steroids are not worthwhile. The good news is most patients will recover if caught and treated early. 2/3 will make a full recovery. So moving to the next topic of non-atherosclerotic, there is this kind of border zone of what I'm going to say is accelerated atherosclerosis in certain vulnerable groups. So conditions that look very much like atherosclerosis, behave like atherosclerosis, but occur in patients that wouldn't otherwise have that much atherosclerosis. They don't have the hypertension, hyperlipidemia, diabetes. And we had a great discussion just a moment ago about disparities. Well, disparities come very much in atherosclerosis, so keep in mind that your African Americans have a higher rate of atherosclerosis at a younger age, and that changes, though, at the older age range. But in particular, the two groups that, or a few groups to highlight, one would be, of course, smokers will accelerate their atherosclerosis. Patients with familial dyslipidemia will accelerate their atherosclerosis. But the uncommon ones that can look very much like it are radiation. So a patient who's had thyroid disease or Hodgkin's lymphoma and is now coming back in their 30s or 40s may have accelerated atherosclerosis. And then sickle cell disease, which causes fibrin deposition and calcification of plaques that look very similar to typical atherosclerosis. So sickle cell disease is one of the most fascinating conditions we have in stroke, and it's one that I do want to take a deep dive on because it's interesting, but also because it's very treatable. So to be aware of, just real quickly, I think we all know how the hemoglobin gets sickled, this change in the amino acid sequence giving rise to the hemoglobinopathies, and that it can come in a number of different varieties. The hemoglobin SS being what we typically label sickle cell anemia, but depending on your other hemoglobins, it could be imbalanced and produce an in-between phenotype. And it's a good history lesson about how balanced polymorphisms come about. From a stroke standpoint, what makes it so interesting is this low oxygen state. And what happens in a low oxygen state, a patient who's stressed for whatever reason may develop a little bit of hypoxia, maybe they have even a chest syndrome with it, and that causes a kind of the worst catch-22. They'll end up having not only the hypoxia, but then they'll have more sickling, and that sickling becomes kind of a feed forward to ischemia. Without treatment, the average lifespan is 14 years. Now, fortunately, that's increased, but still remains rather low at 43. But finding the patients and treating them early, you can often reverse quite a bit of the disease. So what happens with sickle cell and carotid disease is that there's a shear stress on the carotid artery, and that can occur as early as childhood, at age 8. And you'll start to see the same as you would in a patient with atherosclerosis, tortuosity. So tortuosity means that there's a scar in the vessel that's bending it, and in the sickle patients, it's coming from the shear stress of the sickling. They tend to have more disease in the anterior circulation and primarily the proximal middle cerebral artery. And we'll talk about moya fully in a moment, but this is certainly one of those secondary moya conditions that is well associated. And then if it is in the posterior circulations, most oftenly the PCA. So I think this figure really brings together that kind of pathophysiology, that the red cell will sickle, will have hemolysis, and then become a source of poor laminar flow. And as the vessel narrows into the arteriolar and capillary system, fibrin starts to build up because of this shear stress on the wall, and you end up with vascular injury. And so that becomes a scar, not unlike atherosclerosis, and then more and more accumulate over time. So stopping this process is absolutely key. So this is how a sickle cell patient's carotid artery might look with distal carotid stenosis and even MCA stenosis there. So it is one of the most common, it does commonly cause ischemic stroke. Even in asymptomatic patients, many have silent stroke, and virtually all after adulthood have silent stroke. The same shear stress process that occurs and causes ischemia can cause the vessel to rupture, and as a person ages with sickle cell, it becomes more likely that they'll have a hemorrhagic presentation than an ischemic presentation. Again, the shear stress causing dissection, so dissection can be a presentation. The alterations in hemodynamics causing hypertension, overcoming autoregulation and press syndrome, and then just, of course, the hypoxic ischemic from systemic conditions that are causing that hypoxia. So what does it look like on imaging? This is just kind of a heat map that was done of patients who have sickle cell and showing throughout the, really the white matter, those kind of deep white matter area that you expect to see in a 60, 70, 80-year-old, or you're seeing in teens and 20s. But this is the good news. The good news is this is a treatable condition. So this is a condition that's been known to be treatable for over a decade, initially observed in 2006 as what's called the STOP trial, and this was done in children between 2 and 16 years. My favorite diagnostic modality, transcranial Doppler, was the one that was used. So if that's, it should be available in most pediatric hematology settings. If it's abnormal in the middle cerebral artery velocities, those patients are to be, depending on where they're at in the scale, they'll either be transfused or observed, and then continue quarterly follow-up. This is a phenomenal result, 92% relative risk reduction. So I would love to see 92% relative risk reductions across the board in any ischemic condition with a number needed to treat of 7. I used to say that this was the lowest number needed to treat of any cerebrovascular disease, and then clot retrieval came down with about number needed to treat about 2.5. So do those TCDs, keep them going for your patients, and it's, I would say it's not necessarily proven, but it's worthwhile beyond the pediatric years. So if you're inheriting this patient from a pediatric clinic, or they're moving on into the adult world, and you're getting them in their teenage years or 20s, and they've had this follow-up, you should probably continue that follow-up for at least 5 years of symptom-free status before stopping. So other considerations, of course, patients should have blood pressure control. It's if you find them in the ER, if you're getting that call, can you give TPA? Yes, it is okay to give TPA. Statins are not as proven. You know, again, this is not true atherosclerosis from cholesterol buildup, so not yet recommended. And then most pediatricians are giving aspirin for secondary stroke prevention. Consider hydroxyurea. It increases the hemoglobin F production, but does not, unfortunately, show any straightforward benefit to stroke, and it's not an alternative to transfusion. And then consider the patients for moya evaluation and surgery. And then, but this is kind of where we're at with cure, which is bone marrow transplant. There are risks, and it's something to consider. I'll just make one other note that there's a orphan diagnosis for this condition, and a lot of interesting blood products that were developed for alternatives to using human blood for transfusions, and those may help with shortages across many different areas. But in particular, sickle cell patients get a lot of transfusions, and because of that, some of these artificial blood products are now being studied specifically in this condition to avoid that hypoxia. So if it's something that interests you, just be on the lookout for those clinical trials. And that's just what's listed here. So somewhat of a segue from sickle cell to moya moya. Is this a disease? Is it a phenomenon? Is it a syndrome? Yes, yes, and yes. So it really depends on how they get to that point. But what we mean when we say moya moya disease is that it is a non-inflammatory vasculopathy, and it's, of course, not atherosclerotic. And that means that there's no inflammation present, and it's often bilateral. The phenomenon, on the other hand, may apply to any number of patients. Again, it could be your patient who had unilateral radiation. It could be your patient who has neurofibromatosis, who has a unfortunate neurofibroma in their vasculature. It could be a patient who has sickle cell and has developed it progressively on one side more than the other. So all these conditions may arise, may lead to moya moya phenomenon, but we often mean disease as the when there is no other explanation. These are what we just talked about. Keep in mind also your trisomy 21 patients are at higher risk, and there's a large list of other ones that I won't go through, but just keep in mind many of these patients, especially in the adult population, are coming to us without the classic picture. They're coming to us as a progressive vasculopathy from any number of causes, and that you may still treat them as a moya moya patient, and that's exactly what we'll talk about. So this is what the intimal thickening looks like. It's pretty impressive. I think to see that much intima is going to catch the attention of your neuropathologist. What do we see in terms of the disease? The disease has a bimodal age peak, typically in the childhood years, 5 to 10, and then the second peak in the late childbearing years for women, more often in women in that second peak. What do we need to think about when you're seeing a patient in clinic, when you're getting that person who hasn't yet had the evaluation? How do they present? It's often upper extremity TIAs, so that ACA-MCA border zone is where the upper extremity perfusion is. So if you're getting a patient who just has over and over and over, my arm goes weak, especially after, I've skipped a meal or I've had, these are the classic presentation of moya moya TIAs. A number of them are even asymptomatic. Unfortunately, I think of these quote-unquote collaterals as being really weeds. That's how I talk about it with patients, is these are arterial structures that form too fast, and they look like this puff of smoke, which gives the disease its name. But there's some, and we're beginning to see a little bit of the genetics of this, but there's something about the fibroblast structure of the patients that their vasculature grows too much, and then they get too much intima deposition. So these are weak arteries. Not only are they proliferating, but they're proliferating without the typical integrity of a deep penetrating artery, and that can lead to intracerebral hemorrhage. With our population here this is an epidemiological study in Houston, but I'm sure it's similar across Texas. It's a little bit older as the mean age of 32, and there is that female predominance. I don't know why. There is some interesting genetic studies. I don't know if we're going to find that this affects, for some reason, women more than men because of that. And then as patients age, you're more often to see hemorrhage as a presentation. Some cases are familial, and sometimes they're not fully penetrant, and they can be those patients who have something else and I'll tell you the family that I took care of, there was an uncle who had very classic moya moya, bilateral early on. His sister had agenesis of her carotid. So she just had a carotid artery that was present, but it was small throughout its course. And then the patient I was caring for had posterior circulation moya moya, which is pretty rare. So these families will sometimes not necessarily all have moya moya, but they'll have something about their vascular disease that runs through the family. There is, among the patients, increased thyroid disease, and that the patients could be triggered by other things in the environment, like we talked about, trauma, meningitis. If you're not in the stroke realm, but you're in the movement disorder realm, and my colleague Dr. Wong here is seeing some of these patients maybe presenting not necessarily with a TIA. They're presenting instead with a movement disorder that might be caused by ischemia. So limb shaking TIAs classically associated with carotid hypoperfusion. So it could be moi, it could be other things, but these limb shaking TIAs, which could also mimic seizures. The difference with that versus tremor, of course, is the patient has impaired consciousness. So differentiating between seizures and limb shaking TIA is a little bit more challenging, but the patient certainly should have evaluation of the carotids. This was an interesting one. So among your maybe students who are taking up a band instrument for the first time, as they begin to play their band instruments, they may start to develop dyskinesias. So why is that? Well, their basal ganglia is being hypoperfused. So being aware that not only doing typical evaluation, but thinking about maybe including some cerebrovascular evaluation in patients who have dyskinesias. Hemicreatosis, the chronic hypoperfusion of the caudate putamen leading to this prolonged hyperkinetic syndrome. But when the patients are treated, and we'll talk about the treatments in just a moment, they often resolve. So these movement disorders, certainly the carotid hypoperfusion would resolve, but the basal ganglia get better perfusion and they often go away as well. So treatment of moya surgery remains the mainstay. Patients who have surgery, you can kind of tell them, as with any surgery, there's an upfront risk. Depending on the series, that's about 30% of patients have some transient difficulty with surgery, whether it's a seizure or headache or a recurrent surgery. But 2 to 5% end up with a long-term negative sequelae of surgery. So moderate risk surgery. But the vast majority, 67, see a reduction in their stroke risk over time. The what's called the direct bypass, the superficial temporal artery to the middle cerebral artery, remains the most common in adults. In pediatrics, the dural inversion. If the patient's coming to you from a different healthcare system where these kinds of microsurgeries aren't available, they may have multiple burr holes. We'll see that sometimes in patients who are treated in other countries. And then a great word for next year's spelling bee, encephaloduro-arteriosyngangiosis, or better abbreviated EDAS, which is a variation on the burr hole without using the bone and just going directly into the PO to do that indirect bypass. Important point here. There is no role for endovascular treatment for moya disease. So these patients, unfortunately, have been studied, and they've been studied in the context of a group where patients did not want surgery. Patients simply refused surgery and ended up being offered endovascular as a rescue approach, and it did not rescue them. So within about 2 to 3 months, these stents will close off, and unfortunately, that in their series led to fatalities as well. So no role for endovascular treatment in the disease. So this is what the direct bypass looks like. It is taking that superficial temporal artery, putting it into the surface branches of the middle cerebral artery, and reversing flow down into the deep structures. As this matures, the patient may still have those upper extremity TIAs. So don't panic if you're seeing a patient a week or so after surgery and they're still having upper extremity TIAs. In some ways, those weeds, that whatever that is that's causing the vascular growth factors to be more prevalent, begin to work to their advantage now. So they're beginning to grow now collaterals in a way that are not under excessive pressure, and that goes to their advantage, and their cerebral blood flow goes up over time. This is our colleague at TCH, Dr. Dowser's innovation, the Dowser technique, if you're at Texas Children's, the indirect or dural inversion as a form of combined revascularization. Often this is combined with the EDAS. This is what the EDAS looks like, basically tiny little disruptions of the dura and the pia to get the native branches of the middle meningeal artery to grow inside. And then if you want to send your patient away to an institution that does really interesting surgeries, or they don't qualify for direct bypass or indirect bypass, and there's no good donor artery, you can do an omental flap. And yes, that omentum, we're talking about from the gut, bringing it up through the planes of the neck and not disconnecting it, leaving it connected to the abdominal circulation and then overlying it on the dura. So keep in mind that there are going to be patients who are treated and going about their life and then have questions, and one of the most common is, what about pregnancy? So the pregnant woman who has had moya-moya surgery and is stable over many years is fine. She can have a delivery of any type that she chooses. But the woman who has ongoing TIAs, maybe just getting diagnosed at the time of her pregnancy, that's a higher risk patient, and then you may want to consider how to manage that in more detail. There does not appear to be any particular advantage to C-section. So as you look at patients for the different choices that they have, recommending C-section doesn't seem to be particularly helpful. In general, prolonged anesthesia, whether it's with their bypass or something else, is a high risk for these patients, and to really avoid any surgeries for them prior to bypass. Be careful and probably be very cautious with adding blood pressure medicines also before they're bypassed, that they can have strokes from that. Often that's how they're diagnosed. And keep in mind that once they are bypassed, they may see you for headaches. So if you're, unlike me, if you're good at treating headaches, you may be seeing these patients and they'll be telling you that. And what's happened is we basically changed around their circulation and their meninges, and now they're getting a lot of that irritation. Oh, and one quick point. I've seen a number of these women with uterine disease and anemia as a result of fibroids and so forth, and I think we'll eventually discover an association there between the smooth muscle proliferation in the uterus and their intima. So moving from moya-moya to the most common cause of stroke in patients in the adolescents and young adults, so maybe 10 to 35, is trauma and dissection. So about, even though we look for, did you go to, I won't say it, a chiropractor, I did say it, did you have a football event, did you play tennis? There's not always a clear precipitating event. Among people who have, it's sometimes been very mild. I was checking my blind spot and I heard a pop. So if you're in Texas, don't check your blind spot. All the different mechanisms that can be there, and I'll just say the chiropractors will argue that it's not the cause. This is a good way of describing it to patients, I think, is to describe a tire. Many patients know what a tire is. It's got an outer wall and an inner wall, and what happens is the inner wall comes apart from the outer wall, and that space is thrombosed, and that's what a dissection is. They'll often present with Horner syndrome because of the disruption of the sympathetics on the carotid, not from the ischemia itself. So how do we go about diagnosing the patients? If you're using a lot of MRAs, just be aware that this may be the least useful modality. It does vary by institution, so if your MRAs are particularly good, great, but think about adding an MRI soft tissue protocol if you're doing MRI for those patients, as that will add some extra luminal imaging. CTA is very sensitive for luminal narrowing, but really conventional angiography is something to consider. You can see them in the cervical portions with ultrasound, but you can't see the distal ones. So what about angiogram? This is a tough call usually, so by no means is it obligatory to do angiograms in patients with dissections. But what might make you want to think about it is that dissections are often multiple, especially if they're traumatic, so the patient who's in an MVA or something like that. And you may not see them if you don't do the angio. Also, pseudoaneurysms are better seen that way and common, and can cause life-threatening rupture, and so pseudoaneurysm detection is important, and in fact higher risk than true aneurysms. On the other hand, what led to the dissection? It may be that this patient's basement membrane is somehow vulnerable, and doing an angiogram itself is of some risk that you can actually cause a dissection from, and we see that actually in routine angiograms for other reasons that a patient will have a small dissection. So really think about what is it adding to your management, what is it adding to your diagnosis, and if it's already clear what the approach is going to be, doing it to simply better define the anatomy is not necessarily needed. So how do we treat? Well, this is one of those kind of good news. It's straightforward. Antiplatelet monotherapy in most cases. It's not, there's no known benefit of dual antiplatelet therapy. We did do the study for anticoagulation called CADIS, and that study showed no benefit over anticoagulation. It was not inferior, but it wasn't beneficial. And the main downside, of course, is more patients on anticoagulation, in this case warfarin, had bleeds, so not worth using if it's not more beneficial. Stenting is always a case-by-case basis. This is a very heterogeneous condition. We won't make any global statements one way or the other. It is logically preferred if the lumen has a high-grade stenosis or the patient has a contralateral occlusion or some reason that you're very concerned that there's a hypoperfusion from the dissection. Stenting is an option. But for the most part, it's medical management. And even if the artery is occluded, it may reopen with medical management 30% at 6 months. So this is what pseudoaneurysms can look like. The one on the left over there is distal outpouching. The one on the right is a more proximal outpouching. Those are not going to heal with medical management. Those are ones that you'd worry about leaking and may need to treat early. So a moment about vertebral dissection. Very similar pathophysiology to carotid dissection, but more often missed. Why is that? Well, our MRI may not see a tiny distal ischemia in the medulla, whereas we're more likely to pick it up in the supratentorial space. The symptoms are less obvious, these kind of soft symptoms, ataxia, numbness, a little bit of dysphagia. They can also have Horner syndrome, but it's not from the disruption of the sympathetics, it's from disruption of the actual medullary autonomics. So the treatment's about the same, same considerations of antiplatelet, just not included as much in these series, so we have to be a little cautious about making those statements. So what predisposes a patient for dissection? Fibromuscular dysplasia is probably first on the list. It's a very prevalent condition. We see it all the time in our carotid ultrasound lab. Atherosclerosis. Again, going back to those smokers who have a little bit of premature atherosclerosis, they seem to be a particularly high risk of dissection. And then the ones we all are aware of, Ehlers-Danlos and Marfan syndrome. What about beyond the treatment of the artery? It's not uncommon that these patients will have severe pain. This is the most painful stroke. And that will last for months. And in those patients, it can even be up to a year. Thinking about multimodal therapy, thinking about the fact that there's soft tissue inflammation, maybe this is a case for steroids, and then thinking about all your good pain medicines. Moving from dissection to cardiac disease, congenital heart disease that can be treated with a device or surgery, ASD, VSD, PDAs, and then our non-ischemic cardiomyopathies that we generally do anticoagulate patients with an EF less than 20, and we consider it of an EF less than 35%, and you can dissect the WARCEF trial and see what you believe about that. But PFO is the one that comes most often, and PFO is common in the general population and overrepresented in cryptogenic strokes. I just show this graph because I like this graph from the New England Journal several years ago now. This is the difference in patients who are cryptogenic versus known cause, the percentage of patients. Just to point out, what it's showing is the difference in the young versus the old. And we often think of PFO as being stroke in the young. It really is throughout life. And among patients who are over 55 in this series and had cryptogenic stroke or had no obvious cause of stroke other than PFO, it was still overrepresented, statistically significantly overrepresented. So and I'm proud to say we're doing some studies now of the over 60 population for PFO. But just to, age is just a number. If you're seeing a patient who's, in their 40s with a lot of risk factors, they're not behaving like their age. But the converse, if you're seeing a patient over 60 without many risk factors, they're also not behaving like their age. So keep that in mind. So quick summary of what's changed with PFO, just to get everyone up to speed from what we saw, was that there was some of these studies, which I know you are familiar with, came positive. The RESPECT trial using the Amplatzer device in 2013 had a trend, and that trend was interesting but not conclusive. In 2017, it was conclusive with their intention to treat analysis. A reduced trial, this was a different device from a company, Gore septal occluder, and it met its primary endpoint at the same year, 2017. There were other studies, the closed trial that came about, and they were all positive. So with that, the FDA approved these devices for stroke management, and they had a statement, which I think is very interesting, saying that clearly states that patients need to be evaluated carefully by a neurologist and cardiologist to rule out other known causes. So really a call to action for the neurologist to be part of the treatment team. So since that happened, AAN put together a nice group to analyze the quality of this data and put together some guidelines with these questions. Number one question, a patient with otherwise cryptogenic stroke, is closing the PFO better than medical therapy alone? And number two question, if you're going to use medical therapy, is anticoagulation better than antiplatelet? They analyzed the data. I won't go into too deep of detail except to say that the way that the studies were done in PFO, they were open studies. In other words, the patient knew whether they were getting a PFO occluder or not. These were not blinded studies like a medication. So we will not get any level A recommendations because these were not double-blind studies. So our highest recommendations are the should do. So a level B should do means it improves healthcare outcomes, and you should do that. And I'll divide them into diagnosis and treatment. So should do, a neurologist with expertise should evaluate the patient to conclude whether or not this was PFO or non-PFO causes. A cardiac evaluation should be done, including, for many patients, 28 days of cardiac monitoring. Why 28 days? I guess that's the month with the shortest days, but about a month of cardiac monitoring. And then this is probably the most important statement, that when in these well-selected patients, PFO closure probably reduces recurrent stroke risk in the selected patients. The should-dos regarding the treatment, you should inform your patient of the risks and benefits, go through with them what's involved in both options, counsel them that if they are on anticoagulation, that might be lifelong because they've got factor V Leiden or something, and then in those patients it may not be as beneficial. Again, I'm going to highlight my favorite diagnostic modality, TCD, saying that it does get a level C may do, not obligated, but if it's available, you may consider it because it's more sensitive for screening for PFO than TTE, and it may be more sensitive than TEE. What may you do for treatment? These are the level C. You recommend device closure as a may do. You could consider large shunt as a higher diagnostic certainty. You can consider atrial septal aneurysm as something in smaller shunts. You can offer patients who are over 60 closure, understanding that they shouldn't have the typical risk factors. And you can offer it to patients who are under 30 if you feel that that patient's stroke doesn't really match an atherosclerotic presentation, even if it's a small, deep lacunar type infarct. And then whether or not to treat with antiplatelet or DOAC or vitamin K antagonists in non-closure patients, there's no specific recommendation. So to conclude on the non-atherosclerotic patients, I hope I've given you like some of my favorite conditions to evaluate and to treat. But what I really think of when we're asked to do this kind of stroke in the young workup, when we're asked to see a patient, it's often this clanging association with hypercoagulable workups. And really, hypercoagulable workups are rarely helpful. They're often ordered, but they're very rarely do they actually show a condition. The conditions that we do look for that are considerable, worth thinking about are the antiphospholipid lupus anticoagulant, of course cancer, of course oral contraceptives, but those should be in your history, not necessarily in your lab work. And in fact, those conditions, even those conditions, are more likely to contribute to venous clots. And in those patients, they're more likely to have the paradoxical embolism, the cerebrovenous sinus thrombosis, than a primary arterial clotting disorder. And then I've just listed here, these are uncertain role in arterial stroke. Really, if I'm going to opine for a moment, say they really don't cause arterial stroke. You know, factor V Leiden, antithrombin 3 deficiencies, protein CNS, and the prothrombin gene mutation. Same thing with hyperhomocystinemia, does not seem to play a role in arterial stroke. And then what do we do about it if you find these patients and they have a need for treatment? There's mixed results on the DOACs, and in particular for the antiphospholipid patients, the so-called triple positives. It's certainly recommended that they consider vitamin K as their antagonist as their main therapy. And consider it in patients under 50, consider in their over 50 if they have a family history of VTE, prior DVT-PE, and if you're working them up for PFO. So I'll end with hopefully what I look like on the tennis court when I hit my one-handed backhand. Afraid not, but nonetheless, it's something to aim for, and I welcome your questions.
Thank you, Dr. Volpe. I'm not getting any questions online, so if you are submitting your questions but I'm not getting them, please let us know. We need to make sure that this system is working. But in the meanwhile, if there are any questions in the audience, just raise your hand. We'll do it old-fashioned way.
A couple of questions. Could you comment on the role of migraine in stroke and also the role of PFO closure effect on migraine?
Yes and no. So I'll start with the first one. So I would say the migraine effect on stroke, well, there is migrainous ischemia. So the patients who develop migraine to such a degree that they actually outpace the energy demand of the tissue can have infarct, and that's rare, but it can happen. So you can have migrainous ischemia. The more common thing that we see is this kind of little white matter changes. And many of you who know migraine better than me, that's been studied and doesn't seem to correlate really with vascular risks such as late life cognitive disorders and things like that. It seems to remain unclear whether it's because of vasospasm or whether it's because of thickening of the tiny arteriolar lamina. But the harder question is this: if you just come across a migraine patient, should you treat them with aspirin daily, something like that? You know, I think that there are those who would argue yes, because some of them have PFOs and some of them end up having strokes, and aspirin's generally benign, especially in a young middle-aged patient, that there's very little risk. So there are some that say yes, it's not recommended, so there's no need to treat those patients with any kind of primary stroke prevention. The question on PFO has been a controversial one. I mean, there was the MIST trial, the premium trial, and now the relief trial coming on board. What seems to be the question that is unanswered is, what is the biomarker or the selection criteria we use to determine who will benefit from PFO closure for migraine? Because there probably is a subgroup of patients who would benefit from PFO closure, but we don't know how to select them. What's being investigated in the relief trial that's fascinating is clopidogrel. It may be that clopidogrel is a way of, among PFO patients, seeing that if they respond to clopidogrel, they may respond to PFO closure.
I have a question online. How do you feel about CGRPs in moya-moya patients and patients with history of TIA?
Right. Overall, the CGRPs I think are fine in your kind of typical stroke population. They've not been studied enough to know the answer for moya-moya patients. And what was the other one? It was
CGRP in moya-moya in patients with history of TIA.
Yes, in general, okay. Yeah, so no particular concern as long as they're on their other things, so as long as they're taking their aspirin, their statin, their blood pressure control.
Okay. Thank you, Dr. Volpe. It was excellent talk. Our second speaker is Dr. Mark Burish. He received his medical degree at Vanderbilt University and completed residency training in neurology at the University of California. Dr. Burish is assistant professor of neurosurgery at Vivian Smith Department of Neurosurgery and adjunct professor at the Department of Neurology at the University of Texas. and in Houston. Dr. Burrish is director of Will Irwin Headache Research Center. And today, Dr. Burrish will talk about common and rare headache syndromes. Welcome, Dr. Burrish.
Thank you guys very much. I'm going to see if I can get this computer to work. We have some poll questions, hopefully. Thank you very much for having me. The summer TNS meeting was actually the first meeting I ever went to when I moved down to Texas back in 2015, so I'm honored to be part of it today. Before I start, I might want to piggyback on some of the questions for Dr. Volpe because they're kind of around migraine and headache. I feel the same about the PFOs and the PFO closures and migraine. As far as it is kind of a murky area, the risk for stroke with migraine patients is a little bit higher for migraine with aura. There have been some debate on whether patients should get birth control, whether that should be prescribed or not be prescribed. It seems to be highest in patients who are smokers and who have migraine with aura. But again, like he said, we don't recommend aspirin or kind of prophylactic therapy for patients with migraine. So the other part was the CGRP antibodies. The quick story on the CGRP antibodies is this, that CGRP does block or does dilate blood vessels. So in blocking CGRP, you are blocking the blood vessel's ability to dilate slightly. Now, there are obviously other things that dilate the blood vessels, but there was a concern because in animal models, if you give some sort of CGRP inhibitor, the stroke was larger in mice. Now, in humans, they've done a study, I believe it was enreniumab, that did a study in patients who had angina. Now, that's obviously not stroke, but it's another vascular risk factor. Some very brave patients, they gave them a CGRP blocker, put them on a treadmill with an EKG, no change in their angina. So whether the mouse issue kind of translates into humans is a little bit unclear. The concern is not that it would cause a stroke, but that if you had a stroke, it would be slightly bigger because you couldn't dilate blood vessels to get extra blood in. But it's still kind of an ongoing question because the human data so far, at least for angina, was negative. So that's kind of just piggybacking off of him. So see if I can get this to work. There we go. So for disclosures, I've received some funding from a Houston-based nonprofit, like Dr. Juan said, the Will Irwin Headache Research Foundation. I've been a consultant with the AHS, as well as a couple of pharmaceutical companies. Neither of those pertain to any of the headaches I'm discussing today. I did not get paid, but it's worth noting they did pay people who pay me. The other kind of relevant thing, I am an investigator for a couple of trials on cluster headache right now, eptinezumab and vitamin D. So for objectives today, I'm going to start with some vascular headaches, again, to kind of overlap with the lecture you just heard from Dr. Volpe on vascular neurology. Then we'll talk a little bit more about typical headache issues like migraine, cluster headache, and briefly about trigeminal neuralgia. And I plan to do this with some cases, so I'm going to ask for a little audience participation if I can get the online polling to work. Also, the American Headache Society scientific meeting was last month, so I'm going to try to highlight some of the things that are pertinent, some of the new phase 3 trials, drugs that we're expecting to come out in the next couple of years. So this is a case from one of my patients. Obviously, the name there gives it away a little bit, but this is a 53-year-old female with one vascular risk factor, dyslipidemia, who comes in with new headaches. It started about 3 weeks ago, and she's had 5 total attacks. It's a neck and head throbbing pain, and it's a thunderclap. So sudden onset, 0 to 10 out of 10 in less than a minute. And she says it's triggered either by sex when she approaches climax, or once it was just triggered by bending forward, not during sex. And her exam was normal. So don't think it says it's going to be hard. I'm going to ask people if they can pull out their phones or take their computer to vote here. Let's see if I can activate this. The link is pollev, P-O-L-L-E-V, Echo Victor, /Burrish. I don't know for the AV folks if you can just like make a slide real quick and just say P-O-L-L-E-V. You may not be able to, but it's P-O-L-L-E-V .com/Burrish. So let's see if I can make sure it's activated. So it's patient with thunderclap headache times 5, triggered by sex or just by bending forward, and she's had it 5 times in the last 3 weeks. And so again, POLLEV.com/Burish, B as in boy, URISH. So I'll wait until we get a couple results. Some people seem to have figured it out, which is good. And I'll wait a couple minutes. Okay. That may be all we get here. Getting a few more in. So POLLEV.com/Burish. So I'm watching the numbers go up. You guys can't see that, but all right. So we'll stop there. So so most people said B, primary headache associated with sexual activity. It's actually more likely to be our CVS because she once had it without sexual activity. So, so this is. Thank you very much. Oops. So this is primary sex headache. So this is the official definition from the International Headache Society. So at least 2 episodes of pain, so 2 headaches. It's brought on only during sexual activity. So this patient had it once when she was not having sex. So that's not what this is. There's 2 types. There's a gradual one where it increases kind of gradually in intensity with increasing sexual excitement. And there was another one that's more of a thunderclap headache. So it's an abrupt, explosive intensity just before or with orgasm. It lasts somewhere between 1 minute to 24 hours, severe, and they can be a little bit milder for about 3 days. So kind of going through this case, it's less likely to be subarachnoid because she's had this 5 times. It's unlikely, although possible, to get sentinel bleeds 5 times. It's not primary sex headache because she's had it without sex. RCS is definitely possible. Pituitary apoplexy also possible, although you might expect to get some an abnormal neurologic exam with some sort of visual side effects. So this is a definition of a thunderclap headache. And Dr. Volpe talked about this a little bit, but this is subarachnoid hemorrhage until proven otherwise. So that's about 25% of thunderclap headaches. There are other vascular causes primarily of thunderclap headaches, RCVS, like we just talked about, PRESS, strokes, venous sinus thrombosis, a lot of things that you just heard about. There are also some non-vascular causes, intracranial hypotension, some primary headaches. Each of those are kind of self-explanatory, but if you exert yourself or cough or have sex, you can get an explosive thunderclap type headache. Colloid cysts. There is theoretically such a thing as primary thunderclap headache, although we usually recommend you do the full workup, including an angiogram, twice before you kind of make that diagnosis. So let's talk a little bit about RCVS. I know Dr. Volpe overviewed it a little bit. I'm going to go into a little bit more detail. So this is recurrent thunderclap headaches, and it usually happens over a few-week period. It's about 1 month that you get clinical symptoms, and about 3 months that you might see vasospasm. The symptoms are mainly triggered by some sort of sympathomimetic drug or a vascular cause, and I'll show that more on the next slide. We don't know the cause of it other than it's a cause of vascular tone. You may see imaging evidence of vasospasm, or you will see imaging that's usually quite extensive. Brain biopsies are not helpful. You do not see on the histology any inflammation, any vasculitis, any microthromboses. You might see a little inflammation if it's been severe vasospasm for a prolonged period of time, but that's about all you'll see. The CSF is generally normal. You might see a little elevated, a little bit of pleocytosis, white blood cell counts up to about 35, protein may be up to about 100, but otherwise it's normal. And the testing is otherwise normal. And then you can get a variety of complications, which I'll show, mainly bleeds and ischemic strokes. And then the treatment essentially is to remove the triggers and to give calcium channel blockers. So let me go into this in a little bit of detail. So The different drugs and triggers, there are a lot here. These are primarily case reports, but just to kind of, all in these in blue are some sort of sympathomimetic treatment or cause, and all the ones in red are some sort of vascular cause, and that accounts for about half of all the things you see on here. So those are a lot of the causes. Obviously, lots of people take these things or have these issues and don't have RCVS, but these seem to be the triggers. For diagnosis, this on the left is kind of a proposed list of features that essentially describes the phenotype I was already mentioning. So recurrent thunderclap headaches, imaging evidence of vasoconstriction, normal or near normal CSF, and then resolution of the vasoconstriction at a later time. So usually symptoms for 1 month, vasoconstriction for 3 months. Dr. Volpe had mentioned this too, this RCVS-2 score. I also kind of just found this. I have not used this in my clinical practice too much, but it's the same thing. If you have a score of 5 or higher, it's quite sensitive and specific for RCVS versus things like primary angiitis of the CNS. So it's the point system goes, you get 5 points already for thunderclap headaches. You get -2 for intracranial carotid artery. So in general, RCVS does not affect the intracranial portion of the ICA. That's more common in things like moya, but you don't see it too much in RCVS. And then you get points for some sort of trigger, and then if you're female, and if you have some sort of subarachnoid hemorrhage. Usually it's a convexity somewhere, right? So it's basically a non-traumatic convexity subarachnoid hemorrhage. For imaging finding, this is a angiogram that you can even read from the back of the room, but this was a patient with 2 weeks of headache, then developed a right hemiparesis and encephalopathy. This is obviously a dramatic case, but it highlights that beads on a string pattern that's very typical of RCVS. It can affect both the posterior and the anterior circulation. It can affect the external carotid artery and carotid siphon, but as you can actually see here a little bit, it does not typically affect the intracranial part of the internal carotid artery. And then a few months later, that same patient, you'll see full resolution of the vasospasm. The maximum vasoconstriction seems to be about 16 days after symptom onset, but it can change. If you get an angiogram a few days later or a week later, you may see different areas of vasospasm than you did the first time. Here are some of the other issues that you see with RCVS. This is another case showing you can get both hemorrhagic and ischemic strokes with RCVS, sometimes in the same patient. You can also get press and watershed infarcts. So this was a case of a 39-year-old who presented 2 weeks postpartum with seizures and left hemibody numbness, and she had watershed strokes and press. So in summary, with the imaging findings, you can get the kind of beads on a string vasoconstriction pattern, strokes, hemorrhages, press, convexity, subarachnoid hemorrhages, watershed infarcts, but a variety of different findings. As far as imaging goes, and as far as diagnostic workup, the gold standard is a conventional angiography. Indirect angio is about 80% sensitive compared to conventional. So if you have a high suspicion, even if the CTA is negative or the MRA is negative, you can consider conventional angiography. For management, I should say there are no randomized controlled trials. This is all based on observational data and expert opinion. But the data suggests to reduce triggers, exercise. We will tell patients to reduce sex a little bit. Again, the symptom is only about a month, so we're not telling them to give up sex forever, but to reduce those triggers for a defined period of time. We will try some sort of oral drugs to relieve the vasospasm, primarily calcium channel blockers. Verapamil is a little bit easier to take than outpatient nimodipine, but so typically we use verapamil. Like Dr. Volpe said, this is not an issue with angiitis. There's no data for corticosteroids in RCVS. There is some data for intra-arterial interventions to reduce morbidity. So there have been a few things that you can see that have been tried intra-arterially. The consensus is that it really should be restricted to people that are showing clinical progression, but a lot of the fatal cases were refractory to intraarterial. So it may decrease morbidity. It is yet unclear whether it actually changes mortality. But this is kind of the management for RCVS. So hopefully that was a nice transition from the last lecture. You may not think we were starting with a headache lecture on RCVS, but let's now turn to kind of some more traditional headache topics. So this is a 36-year-old female with a history of migraine with aura who presents with changes in her attacks. So for the AV team, I may need some help activating a video here. Thank you. So this is a patient, this is her old migraines. This is what her history is. So she had 3 migraines a month, pretty low frequency, and she had these visual auras that look like this. This is sped up a little bit. This is a 1-minute video. Normally this would happen over about 20 minutes. So it's a visual aura. She describes a central scotoma with this kind of crescent shape or backwards crescent shape, kind of zigzag kaleidoscopy kind of thing. And it slowly enlarges over the course of about 20 minutes. No headache during any of this. It gets to the point where she can't really read very well out of most of her visual field. She doesn't feel comfortable driving because she might hit something over there. And then it kind of slowly fades away, and the headache comes on, the full-blown migraine, light sensitivity, noise, and everything else. So that was what her old headaches looked like. If I can, I may need you to activate out of there. Thank you. And then this is what her new migraine aura looks like. If you can activate that, hopefully the voice.
CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy vertation tonight. We had a very Darrison, let's go to Terrace Chase English for the bit, the head of the pit.
All right, so that is an actual.
And the Grammy?
Oh, yeah, you can forget the Grammy part. That was that was an actual reporter who had a migraine aura, expressive aphasia, live on television. It is the one time in history the one day in history migraine was Googled the most. I believe it still has not been beaten, but she had a migraine aura live on television. So this is, for the purposes of this case, that is your patient. She now has 20 migraines a month instead of 3, and she has a change in her auras. Used to be visual, now she has an expressive aphasia. So AV team, I may need you help clicking out of the video. Thank you. Oh, here we go. It actually seems to be active now. That's great. So if you can go to poll EV again, let me see if, and then let me activate the new. So this is a patient, the question here, it may not be showing up yet. 1 second. There we go. So this migraine patient has a change in her frequency and her auras. Do you need imaging for this patient? All right, we've got almost 20 responses here. All right, so let me stop there. I don't know if this will show the answer, but yeah, 82% of people said yes, which I would agree with. I think if you took this in a vacuum, the patient had no history of migraines, and she was coming with expressive aphasia, you'd probably get some workup. That's generally how we approach patients with migraines who have a new feature. If it's something entirely different than they have not had before, especially if it's stroke-like, then we would recommend doing some imaging. So let's talk a little bit about headache treatment updates. So we didn't have a regular TNS meeting last year, so I'm going to go summarize a couple of years of updates for migraine treatment. There's been somewhat of an explosion in migraine treatments in the last few years, driven mainly by medicines targeting CGRP. So all of these treatments here are for migraine. There are some new acute treatments, these so-called GPANTs, the small molecular blockers of CGRP receptors, Remagepan is a dissolvable tablet. Ubrogepant is a tablet that has two different doses, 50 and 100 milligrams. Those block CGRP receptors. There's a serotonin 1F receptor agonist, a so-called DITAN, lasmiditan. This activates the serotonin 1F receptor to block the pain system. It does not cause vasoconstriction. So this is thought to be very similar in mechanism to some of the triptans, but does not have the vasoconstriction risk. You give it to patients who have strokes, who have myocardial infarction, have a high risk of those things, and not worry about the vasoconstrictive side effects. There's a new device, remote electrical stimulation. It looks somewhat like this, although the one on market is a little bit fancier looking. You put this on your arm and then activate it with some sort of phone app, and you activate this when you have a headache, and it's supposed to break the headache. The theory with this, because it's on the arm, the theory is that it is activating a general kind of feed bottom-up system of pain inhibition, and that's how it's blocking the headache. And then just in the last couple of months, one of these small molecule CGRP blockers, Remagepan, has now been approved for prevention of migraine. So you take it every other day to prevent migraine. So now I believe you can order 16 pills a month instead of the typical ones you used to be able to order to get it every other day. In some ways, is hopefully a revolution as far as migraine treatment is concerned. Typically, the risk with all the as-needed medications is medication overuse headache. If you take them more than about 9 times a month for a lot of the medicines, you get more headaches. The idea with the Remagepan for an as-needed is theoretically, if you took it more often, it actually prevents the headaches. So that's been a nice kind of new treatment paradigm, possibly. There was a device that went on the back of the head. It was a magnet that broke. It was supposed to break an aura and later just break the headache. Unfortunately, the company went into bankruptcy. To my knowledge, it is not available anymore. It's hard to get. And I just want to show a few highlights from the 2021 scientific meeting that took place last month at the American Headache Society. These are phase 3 trials, so these are all treatments that I expect to come out, at least some of them, in the next couple of years. One of them is a combination of meloxicam and rizatriptan. This is somewhat similar in theory to the naproxen sumatriptan combination pill. The idea for this one is the meloxicam, according to the company, has some sort of special pharmacology where it gets in faster, but then the meloxicam allows kind of a longer relief period. But that one was shown to be effective for acute treatment. There's an external trigeminal nerve stimulator. This has been on the market for a little while. Now it doesn't have those little wings that go around the ear, so instead of looking like a tiara, it looks more like a little Star Trek-y thing in the middle of the forehead. That's been used for a while to prevent migraines, but there's some data now that you can use a different setting or use a setting to break a migraine as well. And then there's a combined stimulator. This is an occipital and trigeminal nerve stimulator, so there are stimulators both in the front and the back of this device. So it's a non-invasive stimulator that actually works for occipital. This was also shown in phase 3 studies to be effective for breaking migraine attacks. Finally, there is another G-pant called atogepant. This one's used exclusively for preventive treatment. So this is in the same family as the Remagepan and the Ubrogepant that's come out recently, but this one's, you take it daily to prevent the headaches. And then finally, just one note of a failed trial. We're all hopeful that the CGRP mechanism would be helpful for post-traumatic headaches. Fremanezumab was tried in a phase 2 trial and was no different than placebo for being a treatment for post-TBI headache. Now, whether that means all the other ones will be ineffective is unclear. For example, in cluster headache, fremanezumab was not found to be effective, but galcanezumab was, so that doesn't now, and there are questions about the study design for why those are different, but it doesn't necessarily mean that they're all worthless for trying for TBI. But that was one failed trial that was notable. This is a fairly complete list of all the as-needed treatments in common use for migraine. And I got a lot of this from a recent article in Continuum. The levels of evidence come from the American Headache Society and the American Academy of Neurology. Essentially, level A is 2 clinical trials. As most of you know, level B is essentially 1 clinical trial, and level C is some sort of other good cohort data or something to that effect. But as you can see, we don't have that many categories of acute treatments for migraine. You have your traditional analgesics, NSAIDs, and triptans, your even more traditional ergots, opioids, and butalbital, and then combinations of those. So these ditans and gepants that I had mentioned before, which don't have any evidence yet because they're too new to make the guidelines, in theory, that's a very hopeful kind of opening of new mechanisms, or somewhat new mechanisms. So I say somewhat because they kind of work in the same pathway as the triptans and the ergots. So this is an image of a trigeminal nerve terminal, kind of on the top part, and then just a small blood vessel over there on the bottom. The triptans and the ergots activate serotonin 1D, as in a delta, and 1F in some cases, and that seems to lead to inhibition of CGRP release and blocking other pain signal release. But they also are serotonin 1B or 1 Bravo agonists, and that causes vasoconstriction. The ditans, like lasmiditan, was the only one. So lasmiditan activates the serotonin 1F, but not 1B, not any of the other receptors. So it does not have that vasoconstrictive effect. It only has the trigeminal nerve blocking effect. And then the gepants directly block CGRP by blocking the receptor. So they're not exactly new mechanisms, but they're somewhat new. And then in some cases, there may be this hope that maybe they don't have the same risk of medication overuse headache that the other ones did. So one last, I'll open this up. This is basically just a question on which is your favorite preventive treatment for migraine. So we're going to take a case here. This is a patient who's going to start her first preventive. So she's never taken a migraine preventive before. She has no past medical history. She has an IUD, so pregnancy is not an issue. No concerning findings on imaging. She's paying cash. She's obscenely rich. Money is no object. So basically, in a perfect world, what treatment do you recommend for a patient like this? I'll give it another second here. And then unfortunately, I wish I could show you guys, but I'll just have to tell you the results. I've got a couple more. People have strong feelings on this than they did on some of the other questions. All right, so we'll stop that there. There's no right answer to this one. So I'm just going to go through them. Amitriptyline, 5%. Candesartan, none. The CGRP antibodies, 55%. Onabotulinum and propranolol, both 5%. Topiramate, 25%. Venlafaxine, nothing, and something else, 5%. So it basically goes the CGRP antibodies, topiramate, and then kind of a smattering of a few other things. Again, no right answer to this. I was just more curious what people thought as far as what they'd like to start. This is kind of this is a fairly complete list of all of the preventive treatments. Many of you are very familiar with these. This also includes the nutraceuticals down at the bottom. Again, all of this is evidence from the American Headache Society or the American Academy of Neurology. There's a new category here, level U, simply means the evidence is unclear. There are some with no evidence. The ones on the top, the older ones there, the levetiracetam, pregabalin, nortriptyline, duloxetine, are generally used despite the lack of evidence and still use this continuum article from 2021 at the bottom mentions all of those as things that have some evidence for them that are used. And then there's obviously all of the new treatments here. But you can see that there's been an explosion of new treatments. Memantine has some new data. It's used by some headache specialists. The devices there at the bottom don't have a recommendation yet. So how do you choose which one to give? There's not a lot of head-to-head studies. Obviously, people in the room have very different ideas about what they would prefer to start with. I now often go by side effects. If I don't have a contraindication, if I don't go by something else, I might go by side effects. But what I wanted to point out with this is that if you look at side effects, this is my personal opinion, so this is not data-driven, and you can see if you agree or disagree with the amount of side effects of these. So red is going to be severe, yellow is going to be moderate, and green is going to be minimal. I think that the divalproex, topiramate, amitriptyline, and cyproheptadine have fairly high side effect profiles for a lot of patients. Butterbur there, or pedicite, is not really a side effect. It's more that some of them cause liver toxicity, so we tend not to use those as much. But I would argue that those have some higher side effect profiles. The yellow ones here, the beta blockers, venlafaxine, gabapentin, verapamil, and levetiracetam, kind of have more moderate profiles. Again, you may agree or disagree. And that the rest of these have kind of lower side effect profiles. The ACEs and ARBs, a lot of the onabotulinum injections, the nutraceuticals, and then a lot of these new treatments, the ones that we prefer to use. So whether these new treatments are more effective, or more effective or not is unclear. It does seem like they have less side effects overall. So it just, in my experience as a headache specialist, it's been nice to have patients come in and say, how's it been going with your migraine preventive? Has it been working? I think it's working so far. Any side effects? No, not really. That's just not something you hear when you have a patient come back and try some of these medicines. It's just, they seem to not have the same risk of making you sleepy, or have patients tell you they feel stupid, or having something kind of to that effect. Now, that being said, there are still things coming out about the CGRP antibodies and the CGRP treatments that have issues. People are still asking about the vascular risk factors, which we don't completely understand. There's a little bit more since some of these came out about constipation, hair loss possibly, and hypertension. So there are still some concerns, but in general, they don't seem to have as many of the kind of strong side effect profiles as some of the other ones do. I'm not saying I agree or disagree with the people who said they'd try CGRP antibodies first, but that may be part of the reason why people like them. So then let's switch gears and talk a little bit more about the trigeminal autonomic cephalalgias and kind of cluster headache category. So this is another case, a 33-year-old female with a history of tension-type headaches who comes in with a new headache. So it started 3 years ago, extreme pain, lasting 30 minutes, occurring 1 to 5 times a day, always one of them at 2 a.m. And I'm not going to ask you guys to fill out another poll. We're done with the polls, so don't worry about that part. It's associated with some cranial autonomic features, as well as some restlessness, and she's normal. So severe pain, same side with cranial autonomic features, as well as some restlessness, lasts about 30 minutes. Her diagnosis at this point is either paroxysmal hemicrania or cluster headache. More likely to be cluster headache. It really depends on if that's more 5 times a day or 1 time a day. But there's some overlap between those two. So when you're not sure, you try indomethacin. It's exquisitely sensitive for paroxysmal hemicrania. It's not particularly effective for cluster headache. If it works, they have paroxysmal hemicrania. If they don't, they most likely have cluster headache, and you treat them for that instead. Here are all the different trigeminal autonomic cephalalgias, and you've probably seen slides like this before. The big reason that we separate them, the most important reason to patients at least, is that the treatments are very different. Indomethacin is exquisitely effective for paroxysmal hemicrania and hemicrania continua, but not for the other ones. So you can kind of see that basically you can choose whether to try indomethacin or not, but it really helps you separate them out. SUNCT and cluster headache, which don't really respond to medicine, are pretty easy to sort out based on how many times a day and how fast they are, or how frequent they are. But paroxysmal hemicrania and cluster headache, as you see, kind of overlap. If you have 5 headaches a day lasting for 30 minutes, by definition, that could either be paroxysmal hemicrania or cluster headache. So when there's a patient when a lot of things aren't working, I will try indomethacin just in case there's some overlap to see if I got the wrong diagnosis. Cluster headache of all of these is far and away the most common. So let's talk a little bit about cluster headache. This is a disease that many of you are probably familiar with, but none of you actually seen before, an attack. it is very severe pain, and that's hard to understate if you've talked to patients. We did a question.
Sorry,
Yeah.
it's a cluster headaches. It's more often in men. It's supposed to be a man patient. It's again a female patient.
Yeah. So the question for the people remotely are: this is more common in male patients, and this is a female patient. So it's somewhere between 2-to-1 and 3-to-1 male. So there are a decent number of women that have it. But yes, it's definitely more common in women. I'm sorry, definitely more common in men. It's about the inverse of migraine. But this is the patient's extremely severe pain. We did a study recently where we just gave patients a list of things who had cluster headache, over 1,000 people who had cluster headache, and said, have you had childbirth, kidney stones, everything else? And they said consistently cluster headache was significantly more painful than everything else. Whatever you'd imagine, kidney stones, pancreatitis, shingles, migraines, gunshot wounds, everything else was less painful than cluster headaches. The restlessness in this is also quite profound. So this is a patient with cluster headache. She's having an attack. She's got, you can see the oxygen on as a treatment, and she actually asks her boyfriend to hit her on the head because it helps. You've probably heard some patients with cluster headache saying they want to bang their head against a wall or something, but if you can go ahead and play the video for me, you can just note the amount of restlessness she has. So she can't sit still. Okay, you can stop the video. It's hard to watch, obviously, but I've talked to patients, that does not seem atypical for this is not someone who's acting up because it's on video or trying to kind of exaggerate her symptoms. That is something that's what patients go through. They hit their head, they're in extreme amount of pain, they're very restless, they can't sit still. And if a patient describes something like that to you, it's very different than a patient with migraine, for example, where they say, I just want to lie down, not move, and kind of just have the lights off and just, have everything kind of shut down. So you've all seen the definition before, but it lasts between 15 minutes and 3 hours, usually around an hour, hour and a half. And it happens between once a day and 8 times a day, or once every other day and 8 times a day, usually once or twice a day. There are also several things that are not in the official criteria that are commonly seen in cluster headache, and sometimes they can help in the diagnosis. One is that the onset and offset are very quick. It's not as fast as a thunderclap headache, which is less than 60 seconds usually, but they come on within 5 to 15 minutes. Second, there's some well-known triggers for an extra cluster headache attack, especially alcohol and nitroglycerin, though some people have said that altitude or plane flights can do it. For alcohol especially, the onset is very quick. So I have patients tell me before I finish my beer or before I finish my glass of wine, I will get an extra cluster attack. Interestingly enough, if you have the episodic version of cluster headache, when you're outside the cycle, you can drink all the alcohol you want, take nitroglycerin, it will not trigger an attack. So for the episodic patient, you really have to be in cycle. So I've definitely had patients tell me, yeah, I think I'm at the end of the cycle. That first beer, I'm trembling at the lips to see if I can drink it. And then I know once I drink it and don't get an attack, that I'm finally out of the cycle. The third thing, those quote-unquote migraine features, photophobia, phonophobia, nausea, and vomiting, are actually seen in about half of cluster headache patients. It's often unilateral. They'll say that the photophobia is only on the side of their pain, but they can get all these symptoms as well, so they're not good at distinguishing it from migraine. And then finally, there's this interesting circadian predictability to the cluster headache attacks. So most patients will say that their headaches occur at the same time every day like clockwork. For patient number 1, it might be midnight. For patient number 2, it might be 3 p.m., but it's predictable. We really don't see this clock-like pattern with any other headache with the exception of hypnic headache. Hypnic headache is the only one other than cluster headache. The graph I'm showing you here is 3 large studies in the United States, Denmark, and Sweden that simply ask patients, what time of day do you get your cluster headaches? And the most common time in all 3 studies was 2 a.m., and that's across obviously different time zones. So there's something about the circadian process with cluster headache that we don't fully understand. The other interesting about this is a lot of patients will only have them at night. So even though oxygen is not the most portable thing for a lot of patients, is actually very convenient for a lot of people because they're always home anyway when they're having their attacks. So let me talk about the treatment for cluster headache. It's a little bit different than for migraine. There's a little bit more of a clear first, kind of first line, second line type of thing. So with this one, I'm going to show you the medicine, the recommendation from the American Headache Society, and then the older recommendation from the European Federation of Neurologic Societies. But as you guys know, the recommendations are for how it's not effectiveness, it's more of the data to support them. There's then this, in my opinion, this very well done German study that looked at patients comparing different medications. So they basically confirmed they were taking the correct dose, they were taking them correctly, and then asked people, did you get extra relief for this or not? So it's in kind of a real world patient kind of a survey of how effective these are. The highest recommended are the high flow oxygen and sumatriptan, both by patients and by the recommendations. That 56% for oxygen is probably low. That's because the official recommendations are 7 liters per minute for oxygen. A lot of patients get more relief at 15 liters per minute. There's some data that if you go the higher, it may be just as effective as injectable sumatriptan. Other than that, zolmitriptan nasal is probably the next most effective according to patients, and it has probably the next highest recommendations from the Americans and Europeans. Octreotide does have some data. It wasn't on. It didn't make the list of patient on the patient survey. It just wasn't on it. I have not seen that used regularly. Lidocaine, even though it has some recommendations for it, the patients didn't particularly like it that much, as you can see. They didn't find it that effective. There is a device, the non-invasive vagus nerve stimulator that goes on the neck. That didn't make the recommendations just because it's too new, but it does seem to be effective in breaking the headache for some patients. The advantage of the oxygen and the stimulator is that you can take them multiple times a day, every day, without running significant risks. Theoretically, the triptans, they weren't designed to be taken, 8 times a day, every day for weeks and weeks. There are some bridge medicines. We use these for a few weeks to break a short headache cycle or a flare. You can do steroids either injected or oral. You can also do ergotamine. The problem with ergotamine is that you have to decrease how much triptans you use. So if patients love injectable sumatriptan, most of mine do for cluster headache, and if you start giving them ergotamine, you tell them you kind of got to cut back on the injectable sumatriptan. And then there are a lot of preventives. The new one on the block is galcanezumab. That was shown to be effective for episodic but not chronic cluster headache. So you can only really get it approved for insurance reasons, generally for episodic. Verapamil has generally been the one of choice, but as you can see there, it's not perfectly effective. Not even half of people find it that effective. The next ones patients seem to like are lithium and topiramate. The valproic acid, some patients found it effective, not a lot. The American Headache Society actually came out negative, came out against it, and said the data actually suggests it may not work for what it's worth. And then finally, there's some refractory for patients where nothing is working, generally chronic cluster headache patients. There's 3 different treatments. The sphenopalatine ganglion stimulator is the only one with recommendations. The company unfortunately went under, so it's hard to get that right now. There are some efforts to bring the device back up, but the company went under. There's occipital nerve stimulators, which have some new clinical data for them this year. And then the DBS, the hypothalamic deep brain stimulator, has been used, although the American Headache Society right now actually recommends against its use. The data suggests it did not work. So this is kind of the range of treatments for cluster headache. There's 4 new things I want to cover here just for what's new in cluster headache in the last few years. The first is the galcanezumab, that's been approved. It's a higher dose for cluster headache than it is for migraine. So it's 3 injections of 100 milligrams, and it's syringes. In my experience, however, the cluster headache patients don't mind syringes. They do this a lot for the injectable sumatriptan. The other thing would be oxygen. Right now, it's not covered by Medicare, and a lot of the other insurance companies, as you guys know, have fallen suit. It's hard to get oxygen for our patients. That seems to be changing. So right now, Medicare has underwent this long review with a lot of advocacy from the American Academy of Neurology and the American Headache Society and some others, and they look like they may actually start to approve oxygen. They're kind of in the final stages of that. So we hope that will actually make it all the way through. There may be, well, hopefully the other insurance companies will then follow suit. So that would be very hopeful just to get that approved for our patients. The other two things, the steroids, in the past the data was stronger for occipital nerve blocks. There is a new trial this year that showed that oral prednisone was effective for cluster headache. The dose is high though, so it's 100 milligrams of prednisone for 5 days, and they go down 20 milligrams every 3 days. So it may be that the reason it didn't work for some patients is the dose just wasn't high enough in the past. So it's a quite high dose. I know there's a talk on neuroimmunology later. It's more of that level of dosing for some of these things. So now it's really dealer's choice whether you want to try occipital or oral. And then finally, there's a new study out that showed that occipital nerve stimulation was quite effective in cluster headache patients with were refractory to medicine. So they took chronic cluster headache patients who had tried verapamil, they had tried lithium, they had tried at least one other thing, and nothing worked. And then they put an occipital nerve stimulator in, and it worked in most patients. So even though the other stimulators aren't really available right now, the SPG stimulator is kind of hard to get. The hypothalamic one has recommendations against it. The occipital nerve stimulator does seem to be possibly a reasonable option going forward. And then let's finish up by talking about a neuralgia case. This is a 50-year-old female who presents with kind of a classic neuralgia pain. The onset started a year ago. It's in the right cheek, and trigeminal neuralgia, as you guys probably know, is much more common in V2 and V3. Only about 5% of cases are isolated to V1. But it's a right cheek pain or electric pain that lasts a few seconds, occurs dozens of times a day, and has cutaneous triggers, washing the face, eating, wind hitting the face. And my patients, and you guys have had patients too, they sometimes won't eat. They'll lose weight when it's really bad. They won't go outside, especially if it's cold. And for the men, they'll start growing beards. But there are no associated factors, so they don't have any cranial autonomic features that distinguishes it from Sunkt and Suna, and their exam is normal. So there's no numbness in that area of pain. So this is trigeminal neuralgia. The exam is generally normal. You can have occasional autonomic features with a few of the headaches. So mild autonomic features with a couple of headaches, not all of them, or a couple of attacks does not necessarily make it Sunkt. And you can have very mild numbness of that area, but usually the exam is normal. The new definitions here is classical trigeminal neuralgia. That's the vascular version. You have some sort of vascular compression. It's not just the artery touching the nerve. It has to be actually evidence that it's deforming or somehow compressing the nerve. And so it's a little bit easier to see that on 3 Tesla MRIs than 1.5 for what it's worth. But you actually have to see compression or some sort of morphologic change of the nerve root. Most of them are purely paroxysmal. There are some patients who have kind of this milder pain all the time with shocks on top. Idiopathic trigeminal neuralgia is the one that's not vascular and we don't know what causes it. Again, you can have purely paroxysmal or some continuous pain underneath. And then there's a variety of secondary causes, cerebellopontine angle tumors, AVMs, or multiple sclerosis. And this is just my last slide here for the talk. Treatment of trigeminal neuralgia, it's very clear what the first treatment is. It's very unclear what you do after that. So the first line medication is a sodium channel blocker, either carbamazepine or oxcarbazepine. In general, carbamazepine is thought to be slightly more effective, but less tolerated. Oxcarbazepine is supposed to be a little bit better tolerated. After that, you can try either other medications, other sodium channel blockers, or other medications that, as you can see there. There is a protocol for anabotulinum toxin where you kind of put it in a grid-like pattern, kind of maybe a 2 centimeters or 1.5 centimeters apart, kind of in a grid-like pattern over that area. It can cause, obviously, weakness in that area. A lot of patients will tell you they don't mind if it works, and obviously it's reversible. But that is the kind of second-line medicines. And then there's a variety of surgical procedures. On the right here is pooled data from this reference at the bottom. They looked at pain freedom from patients with trigeminal neuralgia that underwent all these different surgical or procedural interventions with follow-up of about 3 to 11 years. So microvascular decompressions is obviously only for patients with a vascular compression of the nerve. Seem to be quite good for 3 to 11 year follow-up. Otherwise, as you can see, all of them are somewhat effective. You know, pain freedom is quite good for these patients considering how much they're suffering, and all of them have some kind of option, some kind of effectiveness. So in general, it's recommended you try carbamazepine or oxcarbazepine first. Whether you then try other medicines or go to surgery is a little bit of dealer's choice at this point. If you go to surgery, microvascular decompression is recommended if you have the compression of the artery. That's otherwise, which of the other ones you do, if it's idiopathic or something to that effect, it's not quite clear. It probably depends on local factors, whether you have a proceduralist or a surgeon who can do it and whether they're experienced with it. So these are kind of the current treatments for trigeminal neuralgia. So I'll stop there, and hopefully I covered enough, but thank you guys very much.
Thank you, Dr. Bush. We have a couple questions here for you. So the first question is, how long does the headache associated with RCDS usually last? And is the duration of headache longer or shorter than neurological symptoms associated with it?
Say that second part. Is it longer or
What is shorter, what is longer? Headache or neurological symptoms associated with headache?
Oh, got it. So typically the symptoms all in total will be a month. The thunderclap headache part of it is usually fairly short. But I don't know exactly kind of the duration of how long that would take effect. For my patient, for example, she had 5 headaches. I think each of them was severe for a few minutes and then milder for an hour or 2. And then as far as the other symptoms, you know, if you have a stroke or a bleed, you're going to have more kind of longer lasting symptoms, obviously. Other than that, I don't think there's much else.
Okay, and the second question, have you ever seen a structural brain lesion or the neurological symptoms that are typical for migraine aura? That is duration less than 30 minutes and full resolution. Have you ever seen brain lesion?
I don't think I have seen that. You know, there's visual auras. If you have visual seizures, they look slightly different than the typical migraine aura. But I don't think I've seen that from a lesion. I'm sure it exists. The frustrating thing about kind of migraine symptoms is we see that in patients with TBIs, we see in post-craniotomy headaches, you can see in them with bleeds. It's an unfortunately vague set of symptoms that's hard to pin down. So I haven't seen that, but I'm guessing that there are cases of it.
And do we have any other questions in the audience? Yes.
I have similar accent that Dr. Pope, but similar accent. One practical question and one futuristic. Practical, Dr. Eric Eros, who was our co-resident of San Antonio, everybody know Eric Eros, he invented a glycine medication for indomethacin not unresponsive, but indomethacin sensitive patients. Mm-hmm. And he used it and he sells it from his home. He comes every year and he updates us with very good results, maybe 50% results from the indomethacin. If you have some impression with the glycine in cluster headaches and hemicrania especially, continua, and migraine, he also believed that helped in migraine.
Yeah, so That's a brand name for, my understanding, Boswellia serrata, which is an herbal supplement, but that's probably the most commonly used one. It does seem to be effective for a lot of patients with indomethacin-sensitive headaches. It seems to work similar to indomethacin. I do prescribe it for patients with hemicrania continua or paroxysmal hemicrania. Sometimes it works well just by itself. Sometimes it decreases the amount of indomethacin. I believe it works mainly from a similar mechanism, prostaglandin kind of things, but the side effects seem to be much gentler than indomethacin, which is really hard to tolerate.
The second is future risk. You speak about GCPR receptor only. They have 800 of them G protein couple receptors and 800 substrates. Two of them are under study, VAP and PACAP hormones.
Yep.
If you know something about this, I'm very involved in PACAP research and VAP research in literature only. I'm an neurologist and sleep specialist. If you know something about, in San Francisco, they usually have the trial.
Okay. Yeah, so the VIP or VIP receptors, I have not seen much in the way of research into that for headache. The PACAP, so PACAP is another pain signaling molecule that often goes together with CGRP. It's found in the same neurons often. It's another pain signaling molecule. There was a PAC1 receptor antibody that was designed for migraine, and my understanding is in the phase 2 trials it was not found to be effective. Now, I don't think that's the end of it. I do think that it might be more effective for cluster headache for a variety of reasons. It might be, and they're looking at the receptor and not the ligand, but that's as much as I know about that part.
Hi, a few years ago, there was a series of pineal cyst resection for headache, and I'm wondering if there was ever a conclusion, what came of that, the results of doing that?
Yeah, I guess I should qualify that by saying I suppose I'm somewhat biased. My former chairman at UT Houston, Don Kim, did a lot of those pineal cyst surgeries. His kind of idea was, like some of these other things, was you have to find the right patient. But it has not been widely used or accepted to my knowledge. From his side of things, my understanding is that there are a set of patients where it's quite helpful, but it still hasn't been widely figured out which group of patients that is.
I've come across a paper recently, it's a small clinical trial that, based on the fact that they said that CGRP levels are elevated in trigeminal neuralgia, and they've used these the CGR receptor antagonists for trigeminal neuralgia and claimed that it worked pretty well. But have you had any experience with that?
I have, both for trigeminal neuralgia and SUNCT, which is a similar kind of, I've had some good responses for both of those. It makes sense. It's the same trigeminal pathway. CGRP is made primarily through the trigeminal system. I don't know what other people's experience have. I've had patients where it works quite well, other patients it does nothing at all. But yes, I agree with you. It does seem to help.
Hi, Dr. Bursch.
Hey, Dan.
Question about the ARVs and the ACE inhibitors, because I keep always seeing these on as, secondary line agents for migraine. Do you get a sense that they do work? Because, hypertension is very common, and you can kill two birds with one stone. That's always good. And is that a class effect, meaning it's not just those, but that you see it across all ARVs and ACE inhibitors? And then do we even know the mechanism of action? Or
yeah, so I do find candesartan helpful. Lisinopril sometimes, candesartan definitely I found helpful. It's one of my preferred, just for what it's worth. For that reason, it seems there are ancillary benefits to being on an ACE and an ARB. The side effects seem to be lower, except for the cough that you get with some of the ACE inhibitors. The mechanism is unclear. Then again, the mechanism of propranolol, amitriptyline, onabotulinum toxin, all of those, except for the CGRP antibodies, seem to be unclear.
Find with the ARVs, it's candesartan specifically, or any of the...
Good question. Yeah, so I've only used candesartan. I've had patients come in on valsartan or losartan or something, and they already have headaches, so it's not helping. So I don't know. Yeah, that's a good question.
Yes, sir.
That will be our last question.
Is the widespread use of triptans associated with this high prevalence of the Press syndrome and this vasoconstrictive syndromes? Has that anything to do with that?
It's a trigger, for sure. It's a good question. I don't know how many cases of Press are due to triptans versus due to other factors. They're so widely used that you'd think that if they were strong triggers, you'd see it all the time. But I don't know. I haven't seen comments in the American Headache Society literature or anything about we really need to back off because we're causing Press all over the place. But I'm sure it's one of the more common triggers just because of how common they are.
Should we encourage the more widespread use of calcium channel blockers?
For migraine prevention
headaches?
Yeah, so for cluster headache, obviously, verapamil works quite well. I think, or it's one of the top line things. For migraine, it's tough. I think the verapamils and things, some patients and doctors swear by them. They don't have great recommendations. There is one that's not available in the U.S., flunarizine, that lots of people like. We just can't get it here. But I've heard patients, be advised to go to Canada or somewhere else to get it. So I think it just depends on which calcium channel blocker what we can get. But yes, some of them do seem to be helpful. Flunarizine, Flunarizine. I don't remember which type of calcium channel blocker it is, but it's used in Europe, I think in Canada. Yeah.
Dr. Burch, thank you very much for this excellent talk. Let's take a 30-minute break and we'll resume our session at 3:30. If somebody wants a mask but doesn't have one, staff over here have few extra masks if you want to stop by and pick up one. Okay, for the sake of time, let's go ahead and start because we have 2 more presentations. Before we move to our next talk, we have brief announcement. Dr. Hussein.
Hey everyone. So we have a quick announcement. I'm Yasar Hussein, one of the neurologists in Austin, and I head the resident committees. So the past couple of years, we were working to establish a business of neurology rotation for residents, and we were successful to really have a nice curriculum, and we have some of our residency program participated in developing this program. Anyway, because of COVID, we had a setback. So we're trying to reopen again. We have all I'm asking today, if you are interested to have your practice as a site for this training program, it's a 5 business days maximum. It could be a couple days where the neurology resident, the senior neurology resident will come to your clinic, learn the business of neurology behind the scene. It could be private practice, it could be hybrid practice. It's an ACGME approved rotation. They not really will have a patient interaction rather than the behind the scene, how the business is run. We had only, I think, 4 or 5 residents already did it, but we don't have sites all over Texas. We have only 1 site in Dallas and 1 site in Austin and 1 in San Antonio. So if you have interest in this program, just email Kai directly, and really will appreciate your effort to keep this program moving, and it will be of a great help to our residents in the future if they decide to have their own practices and have better knowledge in the business of neurology. Thank you.
Thank you. So our next speaker unfortunately couldn't join us in person, but nothing can stop us from having a great meeting. So Dr. Sabah will be giving us presentation virtually. So Dr. Sabah received his medical degree from the University of Arizona and completed his neurology residency training at Baylor College of Medicine. Dr. Sabah is one of the leading experts in Alzheimer's and dementia. He is the Camille and Larry Ruvo Endowed Chair and Director of Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas. Dr. Sabah will talk today about neuroimaging and dementia. So please welcome Dr. Sabah with his virtual presentation.
Thank you, Dr. Wallen. So my apologies for not being there in person. Normally we would blame COVID or travel restrictions, but today we were going to mention Southwest Airlines because I was on my way to the airport and I had too many delays to get there in a timely manner. So today we're going to talk about neuroimaging and talk about a lot of changes. I know every one of you is hearing about monoclonal antibodies and the transitional changes that are going on. Let me take some time to kind of walk you through what you need to know, not just in imaging, but in biomarkers in general. We all learned that Alzheimer's disease is a diagnosis of autopsy or biopsy confirmation. And the consequence of that is that we do not do biomarker confirmation. And the consequence of that is that diagnosis is typically delayed, and up to a quarter to half will never get properly diagnosed. This is not a trivial issue. These are patients that are waiting up to several years. I never forget, I had a patient I saw who had been seen at Cigna Medical Group in Arizona, had 9 MRIs, all of them with non-specific white matter changes, coded as cognitive change. I walked in the door, 5 minutes, this patient had Alzheimer's as clear as day. So I'm just saying that doctors don't feel comfortable in diagnosing Alzheimer's disease or Alzheimer's dementia. If you look at this slide, you see that it is the actual right-hand side. Our day job is the bottom right-hand side of this slide. And that's because by the time they walk in the door, usually they have a lot of clinical changes, cognitive, behavioral, et cetera. But the changes in the brain that lead to dementia is the end of the disease, is starting up to 20 years before the onset of symptoms. So the dementia is the end of the disease, not the beginning of it. And this is very important. So the first thing I'm going to talk about is I want to talk about a concept called the subjective memory complaint. This is ICD-10 R41.3. When a patient comes in the door and complaining about their memory, we all learned that that just means they're worried and anxious and neurotic and don't worry about it. But in fact, the data clearly suggests that a self-report of a memory complaint is something that should be looked at. And that's why there's now an ICD-10 code. It turns out that a self-informant report of a memory complaint is associated with increased risk of progression. And in other words, when they followed those people that were called worried, well, and neurotic for 10 and 20 years, turns out that they predicted their change in their decline before the cognitive tests or any other tests did. So we need to, I guess the transformational moment here is not dismiss it, but evaluate it and look at it further. People who complain about their memory are more likely to have amyloid in their brain. People who complain about their memory are more likely to be ApoE4 carriers and that they have pathology. So a self-report should be taken seriously and use the right code. Now, the second thing is we're going to talk about is the movement toward biomarker confirmed diagnosis, because what you learned and I learned, of course, is that you can only diagnose Alzheimer's disease with an autopsy. And so that comes from the 1984 NINDS-AD-RDA criteria, which says autopsy or biopsy confirmed. But what has happened is that they recast those data into 2011 criteria. This is the NIAA working group criteria, which said that biomarker evidence was considered advisory but not essential. And this is, I'm going to kind of drill down on this as we get into talking about imaging, biomarkers, et cetera. I want to talk about the fact that even in 2011, they had kind of dug their heels in and said biomarker evidence was not essential. So this is important because what they discovered in 2011 when they came out with these is that dementia is a clinical phenotype. So when you say the word dementia, what you're only saying is, it's like saying movement disorder, right? Or cerebrovascular disease. Dementia means a cognitive decline that is severe enough to cause a functional impairment. So this is important because dementia is a category of disease, kind of like movement disorders are a category of disease. So it is not an etiological diagnosis, it's a descriptive term for a cognitive decline with associated functional decline. Now, if you follow DSM-5, if there's any psychiatrists in this room, they would say major neurocognitive disorder, which only requires one cognitive domain, but dementia usually requires two. So the NIAA working group criteria says basically that progressive cognitive decline, biomarker evidence is advisory but not essential. And this is where the field split, because the American neurology community, NIAA working group, said biomarker evidence was considered not essential but advisory. But if you looked at IWG, the International Working Group criteria, and IWG was the Canadians and Europeans, which said amnestic disorder with progressive features, meaning lasting 6 months or more, getting worse, plus any biomarker evidence, CSF, PET, genetics, genotype, ApoE, anything equals a diagnosis of Alzheimer's disease. This is critically important, and I'm going to spend a few minutes trying to explain to you why you, after today, are going to go back to your clinics and start doing biomarker confirmation of your patients with Alzheimer's, with suspected clinical phenotypes of mild cognitive impairment or Alzheimer's dementia. So what has happened is we're moving toward this framework, and this is the stage 1, 2, 3, but critically important is the ATN criteria. So in 2018, Clipjack et al. Published this called the ATN criteria. A stands for amyloid, T stands for tau, N stands for neurodegeneration. ATN criteria is important, and they're going to add, by the way, by the end of this year, is going to be ATNV, meaning vascular, so they're going to add a vascular. So if you look at the blue box, you need to have amyloid in your brain. We'll talk about amyloid hypothesis if you want. All I can say is that you cannot have Alzheimer's disease unless you have amyloid in your brain. So when you start looking at the clinical interface between pathology and description, you understand, of course, now we're looking at synucleinopathies, tauopathies, amyloidopathies, TDP-43opathies, et cetera. you can have a progressive neurodegenerative condition, but you don't have to have Alzheimer's disease. So by definition, Alzheimer's disease is an amyloidopathy with and without neurodegeneration in tau. So the blue boxes are what is going to happen. So this is a pathological construct, but the reason this is important as a pathological construct is that we were going to find ways to clinically apply this moving forward. And again, I'll get back to the biomarker evidence in a minute. Now, some of you were, look, I was trained in Baylor. I left Texas in 1995, and everybody would say, I know how to diagnose Alzheimer's disease. I don't need an autopsy, biopsy. I know how to do this. Well, the question is do you? So this is a study that was published, my group published a few years ago, followed people with clinical diagnosis of Alzheimer's disease, did PET imaging, amyloid PET imaging them, followed them to death, got their brains. It turned out that even the experts, the world experts in this field, were wrong 1 out of 4 times. In other words, we called Alzheimer's disease in patients who didn't have amyloid in their brain. And so the clinical diagnosis, best case scenario is a clinical accuracy, a diagnostic accuracy of 77%. When they actually go back and look at this in clinical practice with beyond the experts, like primary care, 66%. So we're wrong 1 out of 3 times. That's trying to tell you that the clinical diagnosis of Alzheimer's disease as the cause of dementia is inaccurate anywhere between 1 in 3 and 1 out of 4 times. It doesn't mean they don't have dementia. It doesn't mean they don't have a neurodegenerative disease. It doesn't mean they have Alzheimer's as the cause of their neurodegenerative disease or the dementia. So our approach has been a diagnosis of exclusion, right? Excluding other pathologies. Now we're in the moment in time, and we'll talk about the biologics as the driver of transforming it from a diagnosis of exclusion to a diagnosis of inclusion. So this is the standard practice, right? This is all what we do. You would do structural imaging, B12 TSH MRI. MRI will say chronic periventricular ischemic white matter change and atrophy. That's like every MRI, copy and paste from one MRI to the other. That's hopefully going to change, and I'll explain to you why. And then you have a lot of optional tests. So why do we want to add biomarkers? Well, I just told you that the clinical accuracy of diagnosis is not good. Second, if you actually look at it, most Alzheimer's disease that we call Alzheimer's disease is actually mixed pathology with other pathologies, infarcts, Lewy bodies, hippocampal sclerosis, and TDP-43opathy. So diagnostic accuracy is important. It's important for clinical research. There's high variability in rating scales, and it's very hard to see a clinical picture without the biomarker confirmation. And then we want to see if biomarkers are either diagnostic, meaning binary, yes or no, predictors of progression, or are they predictors of treatment response, what's called a theragnostic marker. And the reason I say this to you is that when in a reductionist mindset, we might use one to do all 3, when in fact that's not the case. Now, the interesting thing about this is that the pathologies and the biomarkers exist. CSF testing exists. Amyloid PET exists. These are not research. They're clinically available. I hope you're doing them. And we'll talk about all of these in the next few minutes. But the point is that a lot of people think that this is all in the research construct. I'm trying to tell you that many of these technologies, particularly the ones on the left, are approved and available, but they're not commonly used in practice. So let's talk first about an MRI. And why do we want to talk about MRI? It's because that's the test that I think we all would say we do routinely. Now, we used to say, okay, well, if I look at the MRI, I can make a diagnosis, right? So if I see posterior atrophy, they may have posterior cortical atrophy. If they have atrophy in the frontal lobe, that means they must have frontotemporal dementia, et cetera, et cetera, et cetera. It turns out that the sensitivity is good, but the specificity is terrible. My point being is that a visual read of an MRI looking for patterns of atrophy is very unreliable in clinical practice. We want to say it's a good idea. That's the way we were taught. We go on rounds, we look at scans saying, okay, frontal lobe atrophy must be frontotemporal dementia. It is not turning out to be that accurately. The specificity is terrible. So a clinical visual read of an MRI does not differentiate one dementia syndrome from another as much as you would think. Enter Cortex, Cortex, the company that has created the NeuroQuant software, which is now a very big deal because NeuroQuant software allows you to measure regions of the brain, and this is the volumetric MRI region. And of course, we like to look at all kinds of things. Hippocampal volume is the thing I look at. So the reason this is a sample of a volumetric scan, and you see here that in this person, their right hippocampal volume is in the 16th percentile, and their left is in the 78th percentile. So this is a normal MRI. The reason I say this to you is if the volumetric change in the hippocampus is below the 5th percentile, that is a predictor of neurodegeneration. So that N would become positive if the 5th percentile or below. Why do I care about the 5th percentile or below? Because neurodegeneration is one of the 4 predictors of progression from mild cognitive impairment to dementia. If you think that we can't predict who's going to progress, we can do it with tremendous accuracy. 4 things that predict progression from mild cognitive impairment to dementia. 1 is hippocampal volume below the 5th percentile. 2 is the presence of the APOE4 carrier status. 3 is the presence of amyloid. And 4 is when their neuropsych measures are tanking below the 1.5 standard deviations, but like they just bottomed out. That would be predictor of progression to dementia. So my point is that when people say, am I going to get worse? The answer is we can predict that with tremendous accuracy and predict how soon even they are going to progress to dementia. So I want you to be aware that the 5th percentile or below on the volumetric MRI is predictor of neurodegeneration. The next thing you need to be aware of is a new principle called ARIA. ARIA stands for amyloid-related imaging abnormality. There are 2 kinds of ARIA, which are microhemorrhages and vasogenic edema, and this is often associated with changes that might be related to the treatment with monoclonal antibodies. So let me spend a minute talking about this. We do know that APOE4 carriers tend to have more ARIA than non-carriers. So let me show you 2 examples of microhemorrhages. I give you egregious examples of them for representation of discussion purposes. Thank God this next patient was taken off of Google and not my patient. So this is a patient with lots and lots of microhemorrhages, as you see all over the brain. This is critically important. So when you are now about to start your monoclonals, and I know there are a lot of you who are skeptical about aducanumab, and I can give you the 20,000-foot view of that. I will say to you that, stay tuned on aducanumab for all your skepticism. Remember that donanemab, lecanemab, and gantenerumab are coming right behind them. And so by 2023, we may have 4 monoclonals, not 1 to choose from. This is a class-specific effect. It's important for you as an audience to understand that when monoclonals start coming into your practice, whether you believe Adu's data or not, you're going to be worrying about things like microhemorrhages. And the rule of thumb is if you have 5 microhemorrhages or more in your brain, there's probability of getting more complications from monoclonal antibody treatment is going to go up. So the reason I say this is that it's not routine in practice for all of us to have your radiologist quantify microhemorrhages. And this would be a good opportunity for them to have a discussion about counting the number of microhemorrhages. The second kind of ARIA is ARIA-E, which is vasogenic edema. And you see a representative. Again, Dr. Google provided me this slide. I didn't want to pull one from my own patients because of fear of I couldn't redact it well enough. And you see here on the left parieto-occipital region evidence of vasogenic edema here. The reason this is important is this tends to be a common complication for monoclonal antibody treatment. Most of the time, it's missed by the local read. It's picked up by the central read. Most of the time, it's clinically asymptomatic. And if it is symptomatic, it's minimally symptomatic. So, you know, a little bit of confusion, a little bit of headache, but nothing that requires spinal taps anymore or hospitalizations or steroids or something like that. Most of the time it resolves without any treatment. And in some cases, you can dose through. So you skip a dose or two and you can go back to treating them. So the point is that vasogenic edema, if you start getting into the treatment of monoclonal antibodies, you will need to be mindful of how to manage ARIA-E and ARIA-H. So let's next talk about PET, because there are now multiple kinds of PET ligands to choose from. The one that we all know about now is amyloid PET. And amyloid PET, the PIB you see in the middle box is Pittsburgh compound B, and of course that's a C11 compound, but there are now F18 compounds. Tau PET has just been approved as fluorotausopir, but Tau PET is not reimbursed. So how do we talk about using these in clinical practice? And the short answer is we're not really. Amyloid PET actually, despite all the things you read about, despite all the things you know, has actually been approved since 2013. Fluorobeta-PIR has been approved since 2013, fluorobetabaine since 2014, and flutamidamol since 2015. These are very important F18 radiocontrast ligands that detect amyloid. And the way they're read is positive or negative, meaning you either have amyloid or you don't have amyloid. And you can see the differences in the brain. The reason I say this to you is that despite another study called the IDEA study, so what happened is these compounds got approved, and Medicare decided that they wanted to do a demonstration grant to determine the clinical utility of the idea of the use of amyloid PET, and they added two specific aims of the IDEA study. So this was a $100 million study imaging 18,000 people, and the outcomes was: one, does it change clinical practice, and two, does it reduce risk of hospitalization? And the answer is that paper published in JAMA by my friend and colleague Gil Rabinovich is yes, it strongly changed clinical practice. So in other words, when a physician had an amyloid PET and it was positive, they were more likely to alter their treatment, change their diagnosis, discuss different things with their patient than if they didn't have an amyloid PET. Now, the thing is the reason that Medicare still doesn't pay, even though 18,000 patients later, we learned that 2 out of 3 times it changes physician habits, is that it only reduced hospitalization risk by 5%, and they pre-specified 10%. And so Medicare still doesn't pay for amyloid PET, and it costs about $5,000. That's why it's not being used in clinical practice, not because it's not available, not because it's research, but it's because it's expensive and it's not reimbursed by Medicare. Now, what about FDG PET versus amyloid PET? FDG PET is, as you see, is going to look at parieto-temporal metabolism for, on the bottom right, you see FDG PET. So when they lose sugar metabolism in the parieto-temporal lobes, you might think of Alzheimer's disease. If they have hypometabolism in the frontal lobes, you might think of frontotemporal dementia. The reason it's important is in amyloid PET is a binary test. So if they have an amyloidopathy, they're going to be positive. So on the left panel, an amyloid PET will be screamingly positive in patients with amyloid in their brain Alzheimer's pathology, and would be negative if they have a TDP-43opathy, FUS, progranulin, C9orf72, whatever mutation you're talking about. This is the kind of thing you would expect to see. So you get different information from amyloid PET versus FDG PET. Now, I have to say I've been a big fan of FDG PET, but since June 7th, I haven't ordered a single FDG PET, except in frontotemporal dementia, Lewy body dementia. I will always order FDG PET and not amyloid PET. So the choice of the PET ligand matters, and that's important for you to understand. Tau PET is now approved as fluorotausopir. This is a really important thing because it turns out that Tau PET recapitulates Braak staging. So Braak is a pathological construct that we use to measure the spread of tangles throughout the brain from 1 to 6. And 1 means sequestered the hippocampus, and 6 means all of the neocortex. It turns out that tau PET recapitulates Braak staging with tremendous accuracy. So Braak and Braak were right all along. And tau PET, this is critically important. Tau PET correlates very well with clinical progression. Amyloid PET does not correlate with clinical progression. Well, I'm going to say that again. Amyloid PET does not correlate with clinical progression. So you have patients with mild, moderate, or severe Alzheimer's dementia. The amount of amyloid in their brain is staying the same from mild, moderate to severe. But the amount of tau and the spread of tau and the location of the tau and tangles is going to change through clinical progression. So my point is that amyloid PET would be a binary yes or no, but would not be a marker of progression, and I would not advise you to use it for a marker of progression. But tau PET could be used as a marker of clinical progression, and that's important for this audience to understand. I do also want to tell you that tau PET is approved. Again, not covered by Medicare, $9,000 a scan, so we're not seeing a lot of use of it. Let's next talk about CSF. So CSF testing is changing as we speak. So you see here that CSF testing, by the way, I too like to do my patient lumbar punctures sitting up. Dr. Wall and I trained in Houston, and we used to do them at Ben Taub, and we'd have spinal tap clinic, and those were happy days for all. I don't know if my colleagues from my Baylor days are in the audience, but we used to do spinal tap clinic at Ben Taub Hospital. But you're measuring 3 proteins, right? Total tau, A beta 42 to 40, and phosphorylated tau. And this is critically important. So the reason I'm kind of moving you past imaging is that, you know, in American neurology, we want to use PET imaging, right? Or MRI and say we're done. That's it. We're good. But it turns out that since June 7th, you have basically to prove the patient has amyloid. If you're going to pursue monoclonal antibody or biomarker confirmation, you either have amyloid PET or you have CSF testing. And now CSF testing has moved to the front of the pack because it's quick, it's way cheaper. I mean, total costs on CSF testing is about a quarter of what it is for amyloid PET. So learning this and relearning this will be important. How good is it? The specificity and sensitivity is overwhelmingly great. There's now multiple studies with tens of thousands of patients, almost 200 studies with 20,000 patients for total tau, for phosphorylated tau, 15,000 patients, and for amyloid, almost 170 studies with 20,000 patients, showing that the specificity and sensitivity are well north of 90% for spec and sense. So what you would expect to see is amyloid levels would go down in CSF, total tau would go up in CSF, and phosphorylated tau would go up in CSF. The other part you need to understand, though, is that CSF testing now used to be typically the Athena 177 AD mark, but now Mayo and Roche have got together, and you can send the CSF testing to Mayo Clinic, and if you decide the patients are going to get Biogen's aducanumab, you can actually put in a request for Biogen to pay for CSF testing as part of your diagnostic evaluation if you're deciding to pursue that as part of your practice. The other thing you need to know is that it is very, very predictive. As you're like, I'd rather do PET than CSF. Well, the answer is that they're overwhelmingly correlated to each other. So if it's positive on a PET scan, it's positive on a lumbar puncture. And if it's negative on a PET scan, it's negative on a lumbar puncture. And it is predictive of progression to dementia. So if you have mild cognitive impairment and your CSF profile looks like it's Alzheimer's, the probability of you progressing to Alzheimer's dementia is 93% in 1 year. So CSF testing is not only highly correlated to PET, but it's highly predictive of progression to dementia. So I want to bring that up, and here's what I just said, basically. And it correlates to PET, as I said already. Well, let's talk about other biomarkers. I think you need to know there's a new biomarker blood test called the C2N precivity test. So a company out of St. Louis, a spinoff of Washington University, has now created a plasma amyloid A-beta 42/40 ratio with a pretty good specificity and sensitivity in the 75 to 83% range. And it is pretty accurate. And I think the Precivity test makes more sense in the negative predictive value than the positive predictive value. So I say this to you because this now is a CLIA approved. Is it covered by Medicare? No. The commercial price right now is hovering around $800. And that, as of right now, it's out of pocket. So I would tell you that the Precivity C2N test is an option that hasn't become widely available. We at the Cleveland Clinic haven't even got it signed up quite yet. But the bottom line is the first blood test as a screening tool to check for plasma amyloid is now commercially available, not research, commercially available. You should expect to see other companies like the Quanterix Simoa platform or the MagQ IMR platform coming to the clinic within the next 2 to 3 years. Now, I know I sit in a minority of people, but I am a strong advocate of the use of the APOE genotyping in clinical practice. And I know that most doctors are like, absolutely not. But you need to know something very important. I just told you that amyloid PET costs $5,000 US. Do you know that if you're an APOE4 carrier in the presence of clinical symptoms, the probability of amyloid in your brain is somewhere between 93 and 96%. And amyloid and APOE genotyping is about $99. Now, I want to give you some tricks of the trade. If you use a CNS code, it's $399, not covered by Medicare. If you use a cardiac code, hypertension, diabetes, coronary disease, hyperlipidemia, it's covered under the Quest Cardio IQ test, and I get it paid for almost every time. So it's just about how you code. Look, we all live in the same world. You know and I know. You got to be creative in your coding to get your test covered. Now, people say to me, what about genetic risk? What about genetic disclosure? What about genetic counseling? That used to be an issue. I'm not going to lie, it used to be an issue. But since 2017, 23andMe will give you your genetic disclosure. You spit in a tube, send it to Boston, and they'll tell you your APOE genotyping without any disclosure or genetic counseling, etc. So thousands of people a day are finding out what their APOE genotyping status is, not realizing that it's a potential proxy test for Alzheimer's risk. So I want to say to you that I use APOE genotyping in my clinical practice in selected cases of mild cognitive impairment and dementia. Not everybody, in the selected cases, and I find it to be highly predictive of progression. So why do you care about biomarkers? Why is this so important? Because if you follow biomarker evidence, it is highly predictive of progression. So on the left-hand side, this is IWG, International Working Group, saying that if you have biomarker confirmed Alzheimer's disease, the probability you're going to progress in 5 years is 95%. And if you're essentially saying the same thing if you use the NIA working group. So biomarker evidence confirming Alzheimer's disease is highly predictive of progression when you follow the Kaplan-Meier survival curves. Now, let's talk about a informant-based, biomarker-driven approach in a recreation of the diagnostic algorithm when it comes to diagnosing Alzheimer's disease. And I'm using the word disease carefully. You hear me emphasizing the word disease a lot, because fundamentally, mild cognitive impairment and dementia are the continuum, and they're both Alzheimer's disease. One is just a lesser severe form of it. Mild cognitive impairment in the amnestic form is prodromal Alzheimer's disease 99% of the time. So if they have mild cognitive impairment with an amnestic form, we might call that a mild cognitive impairment due to Alzheimer's disease. So Alzheimer's disease is the process, and dementia is a severe form of it. Mild cognitive impairment is an intermediate form of it. So a lot of physician people, and especially in the era of the monoclonals. Again, making the point that monoclonals are coming. Whether you buy aducanumab's data or not, monoclonals are coming. And right behind that, after monoclonals, is a whole bunch of other drugs. I believe the Alzheimer's disease therapeutically would be a chemo-based approach, not a one drug, but a 5-drug cocktail. And we are seeing the evolution of that as we speak. And I'm happy to opine on monoclonals if we have a chance to do so. But my point is that we're going to re-engineer the whole process. So kind of a vision of where this could go. One day, you might complain to your doctor, or your primary care physician is doing their annual Medicare visit and saying, is there a memory issue? If they ask the patient or the caregiver, is there a memory issue? Yes. And instead of doing a mini mental, the primary care physician might just do a plasma amyloid test. And if it's abnormal, then they'll refer to the neurologist. And then the neurologist might, when you schedule the appointment, say, hello, patient, thank you for scheduling your appointment. Worth booking out, as we all book out weeks and months. Please click on this link. And then you click on the link, and you'll get, before you go to your office, you'll get cognitive testing on a tablet or a website, and that cognitive testing would be uploaded into the EMR. And so by the time the patient walks in the door, you have their plasma amyloid, you have their bedside cognitive testing, and you can streamline the cognitive and streamline the diagnostic evaluation. So I'm trying to tell you that there's a whole movement underway to re-engineer the clinical approach to Alzheimer's diagnostics. The first thing I would tell you is, instead of, everybody knows how to do a mini mental and MOCA, but what you're missing is the front end of that evaluation process. And the front end is the questionnaires, a structured, informant-based questionnaires. It turns out that there are 3 of them. There is the AD8, which is the most common one. There's the AQ Alzheimer questionnaire, and then a third one called the IQ code. That means that the physician is administering it to the patient, not the patient, but the informant. And scoring, if it scores high, that means there's evidence of impairment. If it scores low, that means low evidence of impairment. And these are structured, informant-based questionnaires. Well, why do we care? Because the sensitivity and specificity is outrageously good for these instruments, and so would be good. So before you do a MOCA or mini mental, you would do informant-based cognitive screening. Second thing I would recommend we do is the question then becomes, how good is it? Well, it turns out that it does predict hippocampal volume loss, informant-based questionnaires. This is a paper we just published in 2021 suggesting that that was the case. It has a very, very good evidence of correlating well with amyloid PET positivity. So if you have a high score on a self-reported informant-based instrument, the probability of amyloid in your brain is much, much higher than if you don't. Second thing I would recommend you do is a risk analysis. So Mia Kivipelto, who's a geriatrician at the Karolinska in Sweden, Stockholm, aggregated all risk that we know about in Alzheimer's risk, and then created a scoring system. And if you score very highly on this aggregated risk analysis, the probability of Alzheimer's changing your brain is overwhelmingly high. So I actually, I added a structural-based questionnaire. I added a risk analysis as part of it. And so you can build these into your practice. In fact, you can build this into your EMR. The third thing you do is the bedside cognitive testing, MOCA, mini mental, mini cog, etc. Now, here's where we're going to change, because historically we would only do the physical and neuro exam and imaging to exclude other pathologies. What I'm trying to say is, let's think beyond that. Of course, we would want to do blood-based biomarkers, as we talked about, potassium ApoE genotyping, plasma A-beta-42, B12 TSH, volumetric changes, etc. And then you would add this algorithm to your practice. And this has been published now for a while. And this is something you could actually embed into your clinical practice. In fact, you could embed this in your clinical workflow starting immediately. So I'm just trying to say to you is that we're moving away from a diagnosis of exclusion to a diagnosis of inclusion. We're moving toward the idea that we can increase the precision without a massive escalation in cost. We're going to use technology to get there. We're going to use an algorithm to get there. We're going to use biomarker evidence of confirmation, and we can be very accurate in the clinical practice now. And with that, I thank you.
I don't have any online questions, so if you have any questions in the audience, raise your hand or come to the microphone. Yes.
Hi, Ron Sargent, General Neurology. Some months ago, there was an article I think posted about the vitamin D levels greater, less than 50 being associated with quote unquote all forms of dementia as a putative risk factor.
So I just want to make sure I heard because it cuts in and out. Vitamin D level is predictive. Is that what you're asking? There is evidence that low vitamin D is associated with increased risk for dementia. That is correct.
Any other questions? Thank you very much, Dr. Sabah. Great talk. Thank you. We are a little bit ahead of time.
Greenberg here. Dr. Greenberg? Yes. Yes, so we can move on. We have our last speaker for today, Dr. Benjamin Greenberg. Dr. Greenberg is Director of Perel Foundation Neuroscience Translational Research Center, Director of Transverse Myelitis and NMO Program, Distinguished Teaching Professor, Interim Director of Neuroimmunology Section at UT Southwestern Medical Center, Dallas. And today, Dr. Greenberg will talk about updates on diagnosis and treatment of NMO spectrum disorders. Please welcome Dr. Greenberg.
So I am all that stands between you and the reception. And we are ahead of schedule right now, and I will keep us that way. Thank you for the invitation to be here. Hopefully everyone's day has gone well, and I'm excited to be here in person. I actually didn't know it'd be a mix of Zoom and in person. I'm not sure which, if you have a preference. If you like the Zoom better, I can do this talk with my head like this to make you, I can watch the screen here. So we're going to be talking about neuromyelitis optica today, and there are a lot of different updates we could do. And for a rare disease, there's been a lot of attention paid to it over the last decade, and I'll try to explain why. And there's definitely a lot to talk about today, but I'm going to limit myself to just a couple key areas, an update on the therapeutics and an update around a specific mimic that has evolved in our understanding over the last 5 years so that you can be on the lookout for this condition. So first, very important in terms of disclosures, there are actually several relevant disclosures to the talk today. I will be presenting data from clinical trials that are published in which I played a role in the trials or working with the group on steering committees or other things. So specifically, what was MedImmune and then Viela Bio and now Horizon is specifically relevant to today. Alexion is relevant to today, and Genentech Roche relevant to today. And I'll try and point that out as we go. So let's put this in context. So this disorder, neuromyelitis optica, has been around for over 125 years. So there isn't really anything new about recognizing patients with this disorder. So Eugene de Vic and his fellow Ferdinand Galt coined the term neuromyelitis optica in the late 1800s. And I don't know if we have any trainees in the audience, but it was actually the fellow Ferdinand Galt who described the syndrome that we now call NMO. But de Vic was the first author, so he got the name, de Vic syndrome. So the rule is you always want to be the first author. And Galt's thesis really formed the basis of this clinical pathologic description of a condition that led to very pathognomonic features. So what are those features? And they're essentially the same 125 years later. So what was described back then were patients who had severe optic neuritis, usually bilateral. So they came in with painful loss of vision in one or more eyes, and or a longitudinally extensive transverse myelitis, so severe paraparesis or quadriparesis, and these patients would have a relapsing remitting form of the disease. They would have events that came on with symptoms and then remitted to some degree. And so because there was this relapsing remitting syndrome, this was lumped in as a spectrum of multiple sclerosis. And in fact, for 100 years, you can read papers with authors and letters to the editors arguing, isn't this just really bad MS? Why are we separating out into its own name and its own disease? So when you compare different definitions over those 100 years of multiple sclerosis to neuromyelitis optica, there was a lot of overlap. NMO was a rarer disease, but there was evidence that it was a demyelinating disease. There was evidence of optic neuritis, transverse myelitis, and it was recurrent. But there were some distinct features that led a group of clinicians to say, we really need to separate this out. We shouldn't lump it together with multiple sclerosis. So what were those features? Why did the clinicians, not the scientists, but the clinicians say that these two patients don't really seem alike? So the first was outcomes. So for those who had gotten a diagnosis of neuromyelitis optica, this was a really bad disease. 50% of patients were blind or quadriplegic over 5 years. A third of patients died within 10 years. Those numbers we've never seen in multiple sclerosis, even in bad multiple sclerosis. So there were outcome differences. If you looked at the brain, neuromyelitis optica was defined as sparing the brain matter. This was a spinal cord and optic nerve disease, and usually we didn't see brain matter involvement. When you looked at the spinal fluid, the sine qua non feature of multiple sclerosis, the presence of unmatched oligoclonal bands in the spinal fluid not seen in the serum, we saw it in neuromyelitis optica patients, but not as frequently. And if you looked at the cell counts within neuromyelitis optica patients, they tended to be higher, and you would see neutrophils. You should never see neutrophils in a multiple sclerosis patient. It should always be a red flag to look for something else. And then finally, when comparing the two, one of the most obvious differences was the transverse myelitis. The multiple sclerosis patients would get short segment, partial myelitis events, the classic dorsal column, numbness, tingling, I can't feel from here down type of event. The neuromyelitis optica patients would get the long, really swollen cords that would present with very profound symptoms. So clinically, there was felt to be a difference. So these differences spurred a group led out of Mayo Clinic, Dean Wingerchuk, Brian Weinshanker, to say, let's come up with a clinical definition that separates out neuromyelitis optica from multiple sclerosis. And they said it needs to be a relapsing disorder, more than one event, with really bad longitudinally extensive transverse myelitis, optic neuritis, but an absolutely pristine brain MRI, and we're going to call those patients NMO, and we're going to call everybody else multiple sclerosis. And when they applied that definition to patients they had seen, what they found was these patients weren't responding to available MS therapies, but they were going into remission with immunosuppression. So the phenotypic definition of the disease had a distinct clinical implication for how we managed our patients. Unfortunately, their definition turns out to be incorrect. This is not an accurate definition of neuromyelitis optica. And how did we get to a change in definition? So it had to do with molecularly defining the disease. So if you took that cohort that Dean and Brian defined as normal brain MRI, bad spinal cord, bad optic nerve, and you looked in their blood, you found a marker, this NMO-IgG, which turned out to bind a protein on astrocytes, a water channel called the aquaporin 4 protein. And this antibody they found in patients who fit the NMO phenotype, but they didn't really see it in patients who fit the MS phenotype. And through a lot of work, they refined this biomarker to associate with the disease with a high sensitivity and specificity. But by having a biomarker, it's important to apply it to the pathobiology of the disease. Why is this antibody important, and what does it have meaning for us as clinicians? So I'm going to only briefly talk about the pathobiology of neuromyelitis optica. And the first thing to recognize is this is not a demyelinating disease. These antibodies aren't binding oligodendrocytes. They're not binding myelin. They're not binding neurons. They bind astrocytes. And if you take a culture of astrocytes and you put in the anti-aquaporin 4 antibody, that middle row, third down, green dotted slide is representing astrocytes that have shriveled up. They're alive, but they're shriveled up and not functioning. Above them are normal, healthy astrocytes that are plump and big and enjoying life. You put in the aquaporin 4 antibody, and they shrivel up and they malfunction. but they're alive. If, however, you add complement to the mix, human complement, now all of a sudden those antibodies and the complement lead to apoptosis of the cells. The astrocytes don't just shrivel up, they shrivel up and die. So when they looked in animal models, and it wouldn't be a Friday at 4:30 without showing a slide of an animal model, you're looking at a mouse brain where they took a direct injection in. They put a needle into the mouse brain and they injected the aquaporin 4 antibody. And what's interesting is if you do this, nothing really happens to the mouse. It just walks around and it's fine. If, however, you add human complement to the mix, all of a sudden you get a lesion that looks like a neuromyelitis optica lesion that you would find at autopsy from an NMO patient. So you need both the antibody and complement in order to get the necrotic lesion. And I'm going to stress that, the necrotic lesion that we've seen at autopsy of severely affected NMO patients. So what did they get about, from a conclusion around the pathobiology of the disease? The first is NMO is not a classically demyelinating disease. So our pediatric center at Children's in Dallas, when I first got there, we named it the Pediatric Demyelinating Disease Center. And then I said, well, crap, now I got to rename the whole clinic because this isn't a demyelinating disease. So now we're a neuroimmunology program. This is actually the first ever described astrocytopathy. This is an immune-mediated astrocytopathy that leads to secondary demyelination. And there has been some beautiful work showing that when you add an antibody into a cell culture, or excuse me, an organotypic tissue culture, for every antibody you add that binds, there's a certain number of cells in a radius around it that get affected. It's friendly fire. And so if you have a lot of antibody, you start affecting the oligodendrocytes, not as a primary pathology, but as a secondary pathology, and that's why you see demyelination. But the antibody can trigger either dysfunction, which is transient and reversible, or destruction if it induces a complement cascade leading to necrosis. And hopefully you get a sense of where I'm going to go with this from a therapeutic perspective. So they had this biomarker, they had a pathobiology that made sense. You've got an antibody, it binds, it activates complement, people get sick, this is bad. But we had a lot of people who didn't fit the original definition that Brian and Dean proposed of optic neuritis, transverse myelitis, normal brain. So we had to look back at our patients and redefine the phenotype. So how useful is this antibody at predicting what would happen to our patients clinically? So I'm going to show you a few vignettes of this. So the first is an example at looking at optic neuritis patients. How many people here have had the referral for somebody who had a single optic neuritis and either normal or abnormal brain MRI? This is a fairly typical referral to a neurology practice across the state and across the US. The presence or absence of this antibody at the time of the optic neuritis is highly predictive of what's going to happen to the patient. So in the top line are seronegative patients, in the bottom dark black line are the seropositive patients, and over 5 years at least half of patients go on to have transverse myelitis if they have the antibody in their blood, whereas it's less than 7% of patients who will go on to have transverse myelitis if they're antibody negative. So testing for this antibody in your optic neuritis patients is a clinically useful test because the people who are positive are bound for trouble in the future. But what about the other syndromes? So remember the definition that was used by Galt and DeVick and Weinschenker and Wingerchuk was longitudinally extensive transverse myelitis. And we were all trained. I looked back, I did my medical school at Baylor College of Medicine in Houston, and I looked back at my lectures on multiple sclerosis. There was one slide on transverse myelitis, and there were two slides on neuromyelitis optica, and they stressed the long nature of the myelitis. And the assumption was if you present with short segment myelitis, it's not neuromyelitis optica. Not true. So in this study, what they looked at was out of 25 patients who were seropositive who had an initial presentation of short segment transverse myelitis. So they didn't present with optic neuritis. They didn't present with longitudinally extensive. They presented with short segment. They went on to look at all the different features of them. And indeed, if you had a short segment transverse myelitis and you were aquaporin 4 positive, you were destined to fulfill the criteria of NMO. You were going to have longitudinally extensive transverse myelitis in the future, optic neuritis in the future. The blood marker trumped the clinical syndrome at presentation. It was predictive. So while we had defined the original cohort based on a phenotype, it was the best we could do clinically. Now with a molecular diagnosis, we could refine the definition. So if we look beyond this to the brain MRI, because remember in the definition it was optic neuritis, transverse myelitis, and a normal brain MRI, we're 0 for 3 in a variety of ways, because we found lots of brain-based syndromes that were seen in patients with the anti-aquaporin 4 antibodies. Some of them very unusual. These posterior reversible encephalopathy syndromes. These are rare. I've only seen a couple of them in my career, but they do happen. But if you look for any evidence of brain lesions, 60% of patients have brain lesions. So if you're waiting for a normal brain MRI to tell you if it's NMO or not, you're going to be wrong more often than you're right. So the presence of a brain lesion does not discount the diagnosis of neuromyelitis optica. And then finally, there were, and I won't go through all of them, but there were some unusual syndromes that we tend not to see on the front line, but it's fun to ask your patients. My favorite is the intractable hiccups and nausea. About 20% of patients untreated at some point will have intractable hiccups and nausea, and they all get diagnosed with gastroenteritis or something else, and it takes 3 weeks, and they're on all sorts of meds, and then it runs its course. This is an area postrema syndrome. The GI docs don't think about it that way, so they never come to our clinic until after the optic neuritis or transverse myelitis. So if you're seeing an NMO patient for the first time, for every 5 you see, if you ask them the question, hey, did you ever have a bout of intractable nausea, vomiting, or hiccups? They'll either say, absolutely, it was the worst thing ever, or they'll say no, and then their significant other or parent will say, yes, you did. Don't you remember when you were in the ER and this happened? So we see this in about 1 in 5 patients, untreated. So let's talk about the assay. Since we're putting so much stock in a blood test, especially if it's going to dictate treatment, how reliable is the blood test? Because it really stinks to have a lot of false positives or false negatives dictating treatment if we're placing so much of emphasis on a molecular definition of the disease. So the original blood test that was used was actually an immunofluorescence assay. So you take tissue, you put the serum on it, and you look for little green dots on the brain, and you say, okay, you have the antibody. Then they came out with an ELISA, which is you put the aquaporin 4 protein at the bottom of a plastic plate, you put the serum in, and you see if the antibody binds to the bottom of the plate. And then they moved on to cell-based assays. So live cells expressing the aquaporin 4 protein, you mix in the antibody from your patient, and you look to see on a flow cytometer if it binds. It turns out that the assay matters. And as you look at the sensitivity and specificity over time, the best assay are ones that are cell-based assays. So the original cutoff for ELISAs of being positive, some commercial labs use greater than 6 units or 8 units, is probably not an accurate cutoff for an ELISA. So if you're sending the ELISA, you really want to cut off of 50. 50 and above is going to be positive. The cell-based assay, if it reports out as positive, it's reliably positive. So where you send your test matters, and you want to ask what assay are they doing. This became such a big deal that it had implications for the diagnostic criteria. And I made this print exceptionally small so that everyone can do a cover-on-cover test of left and right eyes and get your visual acuity for today, free of charge. And the evolution in the criteria from 2006 to 2015, the reason I put this slide up is it got complicated. 2006 was easy. 2006, we had 1, 2 major points and then 3 minors, and it was you needed one of the minors and one of the majors, one of those criteria. It was simple. Then all of a sudden we realized the phenotype wasn't as easy as we thought it was, and the blood test, if done correctly, was quite helpful. So if you can squint and you can read the top diagnostic criteria, what it says is you just need 1 clinical event that's characteristic of NMO, and then if you have a positive aquaporin 4 antibody test and you exclude alternate diagnoses, you have neuromyelitis optica. But in the fine print it says the blood test has to be done on a reliable assay. So you really have to dig and understand what assays are being ordered in order to apply this diagnostic criteria. So now if you have a patient who comes in with optic neuritis and a positive aquaporin 4 antibody, they have NMO. If they come in with a short segment transverse myelitis and a positive antibody, they have NMO. If they come in with a short segment transverse myelitis syndrome and a brain MRI that looks like MS and oligoclonal bands in their spinal fluid, but you have definitively positive aquaporin 4 antibodies in the blood on a reliable assay, it's neuromyelitis optica, not multiple sclerosis. The antibody trumps everything else. Now you have to use your judgment, obviously, but in general that would be the true diagnosis. So the diagnostic criteria have changed dramatically. So based on the antibody and based on understanding the phenotypes, for years we used a variety of immunosuppression regimens to treat our patients with neuromyelitis optica. Steroids, azathioprine, all of these were off-label. None of these are FDA approved for neuromyelitis optica. I'm not sure how many of you have had NMO patients over the years, but if you think back at the beginning, I would spend hours on the phone trying to get approval if we were using rituximab. And all it took was a lot more expensive meds coming out, and now I have insurance companies asking me to use rituximab, and it saves me a lot of peer-to-peers. So what did we know about these therapies? All we had were open label studies, retrospective studies, which by definition, and I'm unfortunately responsible for some of this data because it's not great data. I apologize, but it's all we had. There are biases implicit in a non-randomized retrospective study, but the data held up in independent cohorts over time, which said our immunosuppressive regimens worked. They reduced the mortality, they reduced the rate of blindness, they reduced the rate of quadriplegia. This was not the same disease that we were seeing in the 1980s and 1990s. And of the azathioprine, mycophenolate, and rituximab, most of the data supported rituximab out of the three, although that is definitely argued about in different circles. So this is where we were as we got into 2010 to 2015, but now all of a sudden we had a rare disease that was well phenotyped, that was well described, that had a molecular marker, that had a diagnostic criteria with an understanding of the pathobiology, which means now it's time to look at new therapies and design trials. And that's what I want to update you on. What do we know now about the therapeutics in neuromyelitis optica? So what I want to do is merge what we learned about the pathobiology with what we're going to do therapeutically. So on the top of this slide is the basic cellular anatomy of what we're talking about and where immunology meets the brain. So you have a neuron, it's wrapped in myelin, which is expressed by oligodendrocytes, that olive green color. Your astrocyte is there in peach. What I don't show here are the astrocytic foot processes extending out to the blood-brain barrier, but that's where aquaporin 4 would be expressed. And then you have this pesky thing called an immune system flowing through the blood with T cells and B cells. The B cells become plasma cells. Those plasma cells create antibodies. Antibodies cross the blood-brain barrier, or they get produced within the central nervous system. Both occur. And those antibodies can bind to their target, activate complement, and cause destruction. Gives you a lot of different therapeutic opportunities. You could try and block antibody production. You could try to alter the cells that produce them, or you could alter the activation of the cells that produce them. Since we know that the antibody leads to necrosis by binding complement, maybe you look at the complement pathway. And this leads to the three drugs, which are on the bottom right of your screen table. They're on the left-hand side. Inebilizumab, eculizumab, and satralizumab, which are the three drugs that have achieved FDA approval for neuromyelitis optica. And all of these drugs were chosen to move into clinical trials because we understood the pathobiology. If we hadn't understood that the antibody binds complement, we would have never tried eculizumab in this disease. But understanding that that biology was important led to the clinical trials that we're going to talk about. So what are the trials that you may or may not be familiar with now that have all completed and have led to FDA approvals for all three drugs? The three drugs were studied in 4 different trials. So the satralizumab had 2 different trials, so that's why there's 4 total for 3 drugs. And I'm going to walk you through each of the trials one at a time and then compare. So first we're going to start with eculizumab. I'm going to point out some nuances to each of these trials that are very important for understanding the conclusions and very important for understanding why you can't compare the trials to each other. They are almost incomparable to each other. So eculizumab was a randomized controlled trial, placebo-controlled, 2-to-1 randomization. It only enrolled seropositive patients. You had to have the antibody confirmed on testing. And what it allowed for was patients to remain on their immunosuppression regimen in the trial. So if you were on mycophenolate or azathioprine and wanted to stay on, they would add eculizumab 2-to-1 versus placebo and follow the patients. The majority of patients in the PREVENT trial were on dual therapy. Now what they found, if you look at the bottom, and I'm going to pay most attention to the bottom 2 lines, which is the relapse-free rate at 96 weeks of the aquaporin 4 positive patients, which is everybody who was enrolled in this trial. And 96.4% of the patients on eculizumab were relapse-free, versus 51.9% of the placebo patients. Some pretty big numbers. Going from 50% quadriplegia and blindness over 5 years and a 30% mortality rate over 10 years to 96.4% being relapse-free is a pretty exciting number. Yes? They were on azathioprine or mycophenolate. They were not on rituximab. So they could be on steroids, azathioprine, or mycophenolate. And the 96.4% represents people on eculizumab plus something else. Now, not everybody was on something else. And if you do the post hoc analysis looking at the monotherapy groups, the separation of the curves hold up. It is still an efficacious drug on its own, but these numbers that are reported assume both. So let's compare, or not, as the case may be, to inebilizumab. And I should mention, after the randomization, patients just stayed on the randomized arm until they had a relapse or the end of the trial. So there were some patients who were on placebo all the way through the end of the trial because they never had a relapse. Now, this was different than the inebilizumab arm, the N-Momentum trial. So this was a bigger trial, 230 patients, randomized 3-to-1. They enrolled both antibody positive and negative patients, but the overwhelming majority of patients were antibody positive. Okay? But the intent to treat group had both. And it was a monotherapy trial. You could not be on anything else at baseline. So this is a true drug A versus placebo trial with a twist. And that is the outcome was time to first relapse in the first 6 months, because at 6 months, all of the placebo patients went on inebilizumab. So they had to keep enrolling patients until a certain number of events had occurred and that the curves separated out. So the way they got to the 230 was based on the number of events. So the reason there is no data for 48 or 96-week outcomes is there was no placebo arm at 48 or 96 weeks. So the only outcome you could look at was the percent reduction of relapses, and they were able to achieve statistical significance. Close to 80% of aquaporin-4 positive patients had a significant relapse reduction. Now, in subsequent studies on the open label, which we can talk about, if you look at the aquaporin-4 positive patients and you look at 96 weeks, close to 90% of them, 87 to 90%, are relapse-free. So a big number, but we don't have a placebo arm to compare to. But presumably, it wouldn't have been as good as 87 or 90%. So then finally, we get to the satralizumab trials. And remember, I said there were 2 of them. So in the eculizumab trial, they added on to baseline therapy. In the inebilizumab trial, they said, no way, monotherapy only. In the satralizumab trials, they said, well, let's try it both ways. So they ran one study as an add-on study, and that is the Sakura Sky study. And then they did a study that was monotherapy only, placebo only. That's the last one, the Sakura Star study. One of them was a 1-to-1 randomization, the other a 2-to-1 randomization. They enrolled both antibody positive and negative patients. So remember, eculizumab was antibody positive only, inebilizumab was both, and now satralizumab is both. This becomes important because in the satralizumab study, the benefit was really seen predominantly in antibody-positive patients. There was not a clinical benefit, or at least nearly the same degree as clinical benefit, when you look at the antibody-negative patients. And if you look down at the percent of patients who are relapse-free at 96 weeks in the Sakura Sky study, it was 91.5% compared to 53% of the placebo. And then in the Sakura Star, which is monotherapy only, 76.5% being relapse-free compared to 40% in the placebo. So let's put these all up together. They tell us over and over again, you can't compare trials to each other, and they say it for a reason. These are impossible trials to compare. There are too many factors, too many covariates. Populations that are enrolled were different. The outcome was different. The randomization scheme was different. Whether or not you had baseline therapy is different, but it gives you a sense of several things. Number one is, in antibody-positive patients, they all had a benefit over placebo. So they all ended up getting FDA approval. But you also get a sense that they may be in the same ballpark. If you take the inebilizumab open label data, which said they had 87 to 90% positive on monotherapy, we're basically talking about 87 to 97% being relapse-free over 2 years on one of these drugs. So it leaves you with good choices, but there are differences between them. So eculizumab is an infusible medicine. It is every other week. It's every 2 weeks infused. It's a short infusion every 2 weeks. Inebilizumab, which is a anti-CD19 monoclonal antibody, a B cell depleter, and a plasma cell depleter, is infused once every 6 months. And satralizumab, which is an interleukin-6 receptor monoclonal antibody, so it blocks the activity of interleukin-6, that's an injectable medicine that's ultimately given once a month. Frequent infusions, less frequent infusions, in between injections. So there are differences in the route of administration, differences in the mechanism of action, differences in the biology, but they all have a beneficial effect for our patients. What about the safety? So what I'm going to go through is the safety data for each of these so you can get a sense of what you need to watch for any of these drugs. All of this data comes from the published pivotal trials for each of the specific drugs. So first, eculizumab, which is a complement inhibitor, a C5 inhibitor. Again, I'm going with the small print just to test you on Friday afternoon. I'm going to shout out the important ones. So what we're looking for, what would be the biggest concern if you inhibit complement? It's going to be infections. And really encapsulated organisms, there's a black box warning around meningococcal meningitis or meningococcemia. You're required to get your meningococcal vaccine before you start eculizumab. So if you look down to the adverse events with greater than 15% of patients experiencing it in either group, the number one was upper respiratory tract infections, and it was about 2 to 1 in the eculizumab versus placebo arm. If you look at any serious adverse event, however, so on the serious side, it was equal between the two, between the placebo arm and the eculizumab arm. There was one death in the trial, and we'll talk about that. If you look at the any serious events, though, and you go to the supplement for the paper, there's like 14 tables in the supplement. And this is one of the tips. So it's not, you have to go online, you have to download it, and you have to look at it. But it's interesting to me. On the eculizumab side, there were 9 serious adverse events that the investigator thought was related to the trial agent. And there were 9 serious adverse events on the placebo arm that the investigator thought was related to the agent. They were blinded. They had no idea. But if you look at what those 9 were, the majority of the 9 on the eculizumab side were bacterial infection related. There's a pneumonia, a bronchitis, a cellulitis, a gallbladder empyema, an infection, pleural effusion, and the one death was from an empyema associated with a pneumonia on the eculizumab side. There were, on the placebo arm, mainly viral infections when you looked at the infections. And so whether that's significant or not, I don't know. It wasn't analyzed in the paper. So in the open label extension of this study, 137 patients went on to get eculizumab. So everyone who was on placebo was offered eculizumab. And what we saw were the rates of adverse events and serious adverse events per 100 person years basically stayed the same over time. The most common were headaches and upper respiratory tract infections. The common serious adverse events other than relapses were pneumonia, just below 3%, and urinary tract infections, just below 3%. The one death, which I already mentioned, was the pulmonary empyema. There was one patient who developed Neisseria gonorrhea in the open label extension, but there were no patients with meningococcal infection over this period of time. So the black box warning so far, we haven't seen a big issue with. If you look at the disease for which eculizumab is already FDA approved, which is paroxysmal nocturnal hemoglobinuria, or PNH, I have not treated a patient with PNH before, but this was a life-changing drug for these patients, the complement inhibition. They are seeing a low rate of meningococcal infection, including meningococcal meningitis, even in vaccinated patients. So it's just a word of warning as you use eculizumab, which is a very efficacious drug based on the randomized placebo-controlled trial for NMO. You do want to watch for infections. You still want to watch for meningococcal. So the patients who call you with headache and fever, they should just come on in and get tapped and be evaluated for infection. So let's look at the safety data for inebilizumab. And remember, this is the anti-CD19 monoclonal antibody, the B cell depleter. So what we were looking for were infections. And what was interesting in the study, if you look at the serious adverse events and you compare the inebilizumab arm to the placebo arm, and remember this is a true placebo arm, these patients aren't on any other immunosuppression, a lot of our patients get infections even without the drugs we give them. In fact, an equal number of patients got infections on no drug as people who are on inebilizumab. We couldn't see a difference in the infection rate. And this was true up and down in terms of different types of infections. Now, they were only during the study in the double-blind period for 6 months, so it's not a lot of time to follow them. So if you look after the 6 months to the open label extension, the most common adverse events were urinary tract infections in about 1/5 of patients, nasopharyngitis, and you can read the rest. Serious adverse events occurred in about 1 in 8 patients. One of the questions that has come up when you deplete B cells and plasma cells is, will you induce hypogammaglobulinemia? Will you see a decline in immunoglobulin levels? And indeed, there is a certain percent decline, this was just presented, I don't have the slide, on immunoglobulin levels when on inebilizumab, such that over 4 years or more, your total level goes down by about 25 to 30%. But what was interesting was it wasn't associated with an increased risk of infection. So if you look at people who got infections versus not, the split on their antibody levels were all over the map, were the same. And so while there is some reduction, it's not one-to-one correlating with infections. So finally, we're going to look at the satralizumab safety data. This is a little more complicated because remember there are 2 trials. The first data is from add-on therapy. So these patients were on more than one immunosuppressant, and indeed there were a fair number of infections. 60 to 70% of patients got some sort of infection. Thankfully, it was less than 10% getting a serious infection. If you look at the monotherapy for serious infections, again, it was in the 10% range. So whether you added it on to azathioprine, mycophenolate, steroids, or you used it as monotherapy, somewhere between 5 and 10% of patients would get a serious infection. It's worth noting that with satralizumab, you do have to monitor neutrophil counts. There's a very rare event of neutropenia with satralizumab, so the label has recommendations for following neutrophil counts when you start it. So if you look at satralizumab for the pooled data, you put these trials together, what you found was that compared to placebo, the rates of adverse events were not significantly different. When you looked at serious adverse events, they were not significantly different. When you looked at infection rates, the infection rate was lower with satralizumab compared to placebo. If anyone can explain that to me, I'm happy to meet afterwards. 4 patients in the satralizumab arm and 6 in the placebo arm withdrew due to a study AE, and there were no deaths and no anaphylactic reactions reported. And then finally, if you look at the pooled open label extension, so that was the double blind period. They've been following these patients now for several years. And thankfully, what we're seeing is in the open label extension, the rates of infections are not going up. So you might say, listen, the longer you block IL-6 receptors, you're just asking for trouble and more infections will come. So far, we're not seeing that happen in the open label extension. The serious infection rate in terms of events per 100-person years is below 4, which is what we were seeing during the double-blind period, which is better than what we saw in the double-blind period. So far, we seem to be getting away with this immunomodulation or immunosuppression. All right. All of these agents are FDA approved for seropositive, antibody-positive neuromyelitis optica spectrum disorder. So when you get a patient in with optic neuritis, transverse myelitis, some sort of CNS event, and they have a positive antibody and you've made a diagnosis of NMO, these are the 3 FDA-approved therapies you can choose from. We can have all the conversations you want at the end. How do you choose and whether you use off-label or not, but these are the 3 that have a label. But notice the approval is for seropositive. Well, what about all those patients who had the phenotype but were seronegative? There are patients coming in with optic neuritis and transverse myelitis who test negative for the aquaporin 4 antibody, but you look at them and you say, well, this doesn't look like MS. Well, what do those people have? A lot, and probably a majority, depending on the study you read, have a different condition known as anti-MOG associated disorder, or MOGAD, because everything needs an acronym. So what is the anti-MOG associated disorder? Well, first, what is MOG? So the reason we make acronyms is otherwise the words are too hard to say. So myelin oligodendrocyte glycoprotein is what is MOG. It's a CNS expressed protein similar to aquaporin 4. We find it in brain, spinal cord, optic nerve, but this is a myelin protein. It's not an astrocyte protein. It's not a neuronal protein. It's a myelin protein. And it gets produced late in myelination. And so obviously if you had an antibody against this, we would worry about a demyelinating disease. And indeed for years, there was literature associating anti-MOG immunology with demyelination. So if you look at mouse models of multiple sclerosis, using an anti-MOG antibody is a great way to induce EAE. If you get T cells that react to MOG, great way to induce mouse-based demyelination. And if you put both together, the anti-MOG antibody and the anti-MOG T cell, you get a really bad disease. And guess what those mice present with? So if you have a mouse that has a T cell against MOG and an antibody against MOG, they present with NMO. The mouse has severe bilateral optic neuritis and horrific transverse myelitis. So the double transgenic mouse is actually the best natural animal model for NMO, but it's the wrong antibody. So what do we think humans with anti-MOG antibodies get? Well, for 30 to 50 years, we didn't know. There were papers that were coming out left and right from labs that would find anti-MOG T cells in patients with MS or anti-MOG antibodies in patients with MS. But they would also find these in other people. They'd find them in folks with ADEM, they'd find them in folks with migraines, and then all of a sudden labs started sharing blood, and you would get one result in lab 1 and a different result in lab 2. Remember when we were talking about the aquaporin 4 antibody assay, I stressed how important the assay is. If you're going to make clinical decisions on a molecular diagnostic, you need to trust it. Nothing was trustworthy about anti-MOG testing. You could not get reliable results. And so when we looked at this spectrum of demyelinating disorders, multiple sclerosis versus neuromyelitis optica versus monophasic diseases like ADEM and transverse myelitis, while we were seeing antibodies to MOG in a variety of conditions, including patients with MS, it wasn't specific. We couldn't reproduce the findings. The assays could find, using certain versions of MOG, could find the antibodies in ADEM patients, but not MS, and the data was all over the map. So then a group out of Oxford in 2015 published in the Green Journal a better assay. And for anyone who wants to geek out on assay immunology, grab 2 drinks, and then I'll send you the PDF of the paper. It looks like this, and it's a phenomenal paper. It is a great paper for 2 reasons. And I'm going to geek out for 5 minutes because we were early tonight, and so I'm going to try and keep you awake with this. So what Patty Waters figured out from Oxford was 2 very important things. Number 1 is, if you use a short-length MOG versus a full-length MOG, the assay acts differently. You get different binding patterns. The second thing he figured out, which is truly remarkable, was the way these assays work, like the ELISAs or the cell-based assay, is you have your target antigen, you take my blood, you take out the serum, and you put it in and you bake them together. And then what you want to know is, did I have an antibody in my blood that bound that target? Well, they don't come with self-labels that glow in the dark, so you have to add a secondary antibody. So what you do is you add a secondary antibody with a little green tag on it that would bind to human IgG. So if one of my human IgG antibodies bound to what was in the dish, it would light up as green. So Patty figured out 2 really unfortunate things for history. Number 1 was the MOG antigen will non-specifically bind IgM from your blood. We have no idea why. But that shouldn't be a problem, right? Because the commercial lab that sold me that tag, that secondary antibody that's IgG specific, it said so on the label, I paid my money, and they sent it to me. If there's IgM sticking to the plate, it shouldn't matter. Turns out they were wrong. It was non-specific. It would light up IgM and IgG. 2 just random events occurred so that lab after lab after lab would get non-reproducible results. So when he fixed this and used a pure antibody that only binds to IgG, all of a sudden the assay was reproducible. And all of a sudden what he found was patients who were having optic neuritis and transverse myelitis who didn't have an aquaporin 4 antibody, they were testing positive for the anti-MOG antibody. Now, some of them were being diagnosed with MS, some were being diagnosed with seronegative NMO, but they had a phenotype. And if you remember what happened in aquaporin 4, once we had the molecular diagnostic, we got better at understanding the disease. So now that we had a reproducible assay, what did we learn about anti-MOG associated disease? Well, the first was about the syndromes. We looked at patients with unilateral optic neuritis, bilateral optic neuritis, longitudinally extensive transverse myelitis, short segment transverse myelitis, ADEM or combinations thereof. And what we found was the syndrome a person had, if they had the anti-MOG antibody, the syndrome they had depended on their age. So if you were a child, and what you want to look at is first the middle graph with the pretty colors, what is B, age at onset. And what you see in the pink is ADEM, the very first peak. If you are below the age of 7 and you have an anti-MOG antibody, you present with ADEM, acute disseminated encephalomyelitis. If you're between the ages of 8 and 12 and you have the anti-MOG antibody, you present with bilateral optic neuritis. If you're between the ages of 12 and 18 and you have the anti-MOG antibody, you present with transverse myelitis. And if you're an adult with the anti-MOG antibody, you usually present with optic neuritis, transverse myelitis, or the combination of the two. So your age dictates your phenotype. These kids who were diagnosing with monophasic ADEM and the pediatric neurologist, any pediatric neurologists in the room? One brave soul. The pediatric neurologist who, at age 18, it was diagnosed and adios, go find an adult neurologist, didn't realize at 30 they were showing up on the adult side with optic neuritis. So they were being studied as ADEM patients because they only had one event, but they were going on to have future recurring events over time. And what they found was fascinating relative to recurrence and relapse risks. So number one is if you just take everybody who has the anti-MOG antibody and you follow them out for 5 years, about half will relapse over time. What's interesting is you can break it down by the age groups and you can break it down by what type of attack they had at the beginning, and there are differences between them. The younger you are, the sooner you are to have relapses. The older you are, the more spaced out they are. And likewise, if you look at the folks who had optic neuritis as the onset, they are likely to have relapses sooner than the patients who had ADEM or transverse myelitis. So how old you are, what syndrome you have, are part of the predictor. But anti-MOG is different than aquaporin 4 mediated disease. The attacks aren't as severe and the disability that accrues isn't as severe. So if you look at the top, the probability of having a relapse, what you can't read is the blue line are the anti-MOG patients and the red line are the anti-aquaporin 4 antibody patients. So the anti-aquaporin 4 antibody patients have relapses sooner. They convert to a relapsing course sooner than the anti-MOG, and more of them have relapses than the anti-MOG population. If you look on the bottom left, panel B, which is the cumulative probability of achieving an EDSS score of 3 or greater, the AQP4 patients, they all accrue disability with their relapses. The MOG patients don't. The MOG patients might have relapses, but they recover more from each relapse than the aquaporin 4 patients. And if you look just at visual acuity over time, despite optic neuritis after optic neuritis after optic neuritis, the aquaporin 4 positive patients will achieve a status of significant visual loss or even legally blind to a much greater degree and sooner than the anti-MOG patients. And I didn't put it in the slide deck, but I'll mention we published a paper that still is keeping me up at night, where we looked at patients with multiple sclerosis, the aquaporin 4 antibody and the MOG antibody, and they had all had optic neuritis, and as we measured their optic nerves with OCT, they all had equal damage on the OCT. They had lost equal amounts of axons. The MOG patients had perfect vision, despite 2100 or 2200 vision in MS and aquaporin 4 patients. So despite getting profound damage, and at their nadir, the anti-MOG patient with optic neuritis will come in legally blind, but they recover. They recover their vision, they recover their function. So you have a disease that's antibody mediated, that's causing relapses. There are fewer relapses, there's more time in between the relapses. The relapses are just as severe, but the recovery is greater. So what should we be doing relative to treatment for this condition? You're going to have to invite me back to answer that question when I figure it out. I wanted to put this slide in just as a very important reminder for one of the points I made on the last slide. And this is about MRIs and anti-MOG. And I enlarged 3 of the lines from that table. What percent of anti-MOG patients have periventricular lesions? 26.5%. What percent of them have Dawson's fingers? 8%. What percent of them have callosal involvement? 10%. You cannot trust your MS diagnosis based on pattern recognition on the MRI. There are anti-MOG patients walking around who I think are in perfect remission on their fill-in-the-blank therapy, and it has nothing to do with the therapy. They're just not having relapses because they're anti-MOG patients. And so the pattern recognition is not trustworthy. So where does this lead? The conclusions I'll leave you with are all patients, this is a Ben Greenberg statement. This is not an Academy of Neurology or TNS statement. I'm happy to take blowback and criticism for this, but it is my belief that every patient being evaluated for a demyelinating disease, a CNS demyelinating disease, should have both the anti-aquaporin 4 and anti-MOG antibody tested routinely because it's actionable information. And so even if it is 2 or 3% of our demyelinating population, especially when we have different therapies for aquaporin 4, it is our duty to document whether or not they're antibody positive. These are important mimics to rule out. The treatments for aquaporin 4 mediated disease have expanded significantly, and we need to get comfortable with the different mechanisms of actions, routes of administrations, and monitoring plans. We are all rapidly becoming somewhere between a rheumatologist and an oncologist with the type of drugs that we're using, and I wish us luck. The treatment paradigms for anti-MOG associated disorders are evolving. I used a very vague term on purpose because if we give this talk in 24 months, there will be much firmer treatment paradigms. I can tell you what mine are, but it's not based on anything but open label studies and retrospective studies. But it's important to note it will be very different than anti-aquaporin 4 mediated disease. Who we treat is going to be different. Where aquaporin 4 mediated disease, I treat everybody. With anti-MOG mediated disease, I don't treat everybody. It's person specific. So with that, I think that's the end. Yep, happy to take any questions you have before the reception.
Thank you, Dr. Greenberg. We have a question online. Do we know what triggers acute attacks of NMO?
So what triggers acute attacks for NMO? So we do not know what triggers acute attacks for NMO, multiple sclerosis, or anti-MOG mediated disease. And if there's any neuromuscular folks here, I'd like to know what triggers acute attacks for myasthenia and others. When it comes to immune-mediated disease, we have not figured out why on a Thursday at 3:30 a patient has their relapse. It's one of the holy grails we're looking for.
Any other questions? Yes.
Two questions, actually. Is there data for aquaporin 4 antibody testing on CSF? And then second question is, it's not really a question. Well, I guess it is. What labs do you recommend? Because it sounds like there's some, I don't know, reliability or validity of the testing.
You mean where I send it or what am I testing? Where I'm sending it. Okay. So on the first question in terms of CSF, it's a great question. There are some neurologic syndromes where the CSF antibody is more important than the serum. The classic example is probably the NMDA receptor antibody, where you can have a positive CSF, a negative serum, and the CSF is more associated with the clinical disease than the serum. In NMO, 99+ % of the time, it's serum where the antibody is. There are rare cases, I've had a couple, where the serum was negative but the CSF was positive. So my sequence of events when I'm evaluating a new patient in the outpatient setting has been the following. I send the blood-based test first, because if I get an answer, if I get an aquaporin 4 antibody in the blood, they don't need a spinal tap because I have my answer. And then if it's negative, then I set them up for their spinal tap where I'm doing the traditional IgG index oligoclonal bands and I can add it on there. For the anti-MOG antibody, we don't know. The early data says it's like aquaporin 4. It's in the serum overwhelmingly compared to the CSF. So I'm following a similar paradigm. In terms of where I send it, so where we are, we just have a contract through the hospital labs with the Mayo Laboratories. And so ours go up there because they do the cell-based assay on both of them. There are other places that do the cell-based assay. And so it's really, to me, more a question of what assay is being run versus is it a Quest or a LabCorp or something like that.
Any other questions?
Great talk, thank you. I just heard you, say that you treat all seropositive AQP4 patients. Where do you land on the ones that are seronegative but sure still look that way?
So for the patients who are seronegative, who have had more than one event, So the way I say this to patients is, I don't know what's wrong with your immune system, but there definitely is something wrong with your immune system. I tend to go broader in those patients, and it gets very specific on what some of the potential mimics that I might be trying to cover. The number one neuromyelitis optica mimic that I butt heads against is, am I missing neurosarcoid? And so, because they can have a longitudinally extensive TM, they can have funny issues, and so when the antibody's negative, I tend to still use a lot of mycophenolate off-label because I'm covering more than one entity. The B-cell depleters, we don't have good data for it for sarcoid like we do for things that are cell depleters. Now, that said, we're going to have a paper coming out in the next few months where we have our first patient who tested negative multiple times on a good assay for the aquaporin 4 assay, but we were able to find plasma cells and sequence out the aquaporin 4 antibody. So we know he or she had cells that could make the antibody, but we weren't getting it on serologic testing. So some of those patients do have anti-aquaporin mediated disease, and it's an assay issue, but that number is getting smaller and smaller and smaller.
And those three medications that were approved for seropositive, they're equally approved for seronegative use?
No, they are approved for seropositive. Yes.
Other question?
Sort of a follow-up to hers, but in my case, when I see NMO phenotype and there's seronegative, I go rituximab because I think the European thing said that rituximab's okay with MS. So is that okay for me to do that? Does that seem legit?
It is legit. I mean, it's a reasonable approach. You're covering multiple conditions. It's really that issue of, is there anything in that phenotype that would make you think sarcoid's the example that I use? But the B-cell depleters, we've got great MS coverage as well as NMO coverage. It's not an unreasonable place to go.
And I saw a hand somewhere there. Some other question? Yes.
So the question is there a role of plasma exchange for patients? And the answer is yes, yes, and yes. So in the acute setting, there is very good data to say aquaporin 4 antibody-positive patients have a unique response to plasmapheresis above and beyond corticosteroids. And so it's, like Chicago voting, you do it early and often. So when you're worried about a patient in an acute event, plasma exchange is always a good path to go. We have similar data in anti-MOG mediated disease, but frankly, they're recovering so well acutely, they get better, they respond beautifully. Are we making a difference 6 months out? I don't know. For the aquaporin 4 patients, we are. There have been groups that have looked at using plasmapheresis as a preventative, totally different, where you have patients come in once a week for an exchange. And the data, open label retrospective, is it works. And so we've had a couple patients for one reason or another, either for breakthrough disease reasons or other things, have wound up on once a week plasma exchange, and they've been doing well. I'll tell you the risk to that is you get to the position I'm in with a couple patients, which is I don't know when or how to stop. Because they've had horrific experiences off plasma exchange and they don't want me to stop, but I kind of want to try something else after 6 years of plasma exchange and a lot of peer-to-peer calls. But if it's not broke, we're sticking with it. So it can be used.
Okay, there's another question. Is there an increased incidence of MS following minor trauma?
An increased incidence of MS following minor trauma. So this has been debated and looked at probably for 50 years, and there's studies on both sides in terms of the implications of head trauma to the development of CNS demyelinating diseases. In general, the data is negative for an association, but these are really hard studies to do. So there's a huge issue with recall bias when you do these studies. So if I ask everybody here who's perfectly healthy and has no issues, have you ever had a head trauma? If you had something moderate in high school, you may not recall it when I do the survey. Whereas if you've been diagnosed with something and you're sitting there day after day, how did this happen? You tend to recall things from your past to a greater degree. So the studies are really hard to do, but so far the data is negative.
Okay, there's one more question there.
I was just wondering if you have any thoughts about FcRn inhibitors in combination with a complement inhibitor, or, I've heard people refer to FcRn inhibitors as being like a chemical plex. So any thoughts about whether or not, and if plex is good for the exacerbations, would maybe a combination of that sort be practical in this disease?
In the acute setting or the prevention side, or both?
Probably more in the acute, but prevention as well.
Yeah. So for the FcRn inhibitors, the answer is yes. I think there is definitely a need for a study in that place. This notion of having plasmapheresis in a bottle is a very enticing one, with one caveat. When we talk about plasmapheresis, we're all focused on the antibody depletion event that happens with plasmapheresis. There's 3 immunologically important proteins that get depleted by plasmapheresis: antibodies, complement, and cytokines. They all get depleted. And so whereas on the FcRn drugs, you're going to take the antibodies, but you're not affecting complement, you're not affecting cytokines, why does it matter? So plasmapheresis acts like a sump pump. So as you pull those proteins out of your circulation, they're still on the brain, they're still on the spinal cord, they're still on the optic nerve, but then over the day, they re-equilibrate to the serum, so you then pump it out again, which is one of the reasons why most of our patients on plasma exchange don't get better with the first, second, or third exchange. We usually see them get better with number 4 or number 5 when you're finally accessing the CNS space. We don't know the kinetics for the FcRn relative to the tissue side. So as you deplete it from the blood, how long will it take to re-equilibrate? But I definitely think it's worth study. We did do a shameless plug for the research lab. We did a fun study where we took the anti-MOG antigen and attached it to, so the antigen, not the antibody, we attached it to the backbone of an antibody that would lead to degradation via the FcRn pathway. And in the mouse, we were able to get rid of the anti-MOG antibody without touching any other part of the immune system. So the circulating antibody would bind to the antigen and then get sucked in and degraded by the cells. And so the biology around FcRn is going to be an extremely useful for biology for doing antibody depletion therapies, either specifically or non-specifically.
Any other questions? No. Thank you, Dr. Greenberg.
Enjoy the reception.
Excellent talk.
Thanks.
So the welcome reception will be in the Texas Spice restaurant that is downstairs outside the general session. And announcement for women attendees immediately following welcome reception. For those who want to socialize some more and not interested in Olympics, I guess, there will be networking happy hour at the Jim Bob's Bar that is outside with women neurologist session. So you can join us as well. Thank you very much, and we are adjourned, and we'll meet back tomorrow at 8 a.m.